Ladies and gentlemen, and doctors and specialists and researchers, a very good morning to all of you. Welcoming you all for the second session of 3D Graphy Medical 2022. This is the second day. We had a very interesting day yesterday in terms of having respondents joined in discussing on 3D technology across medical specialization. And we had the privilege of Dr. Girdhar Gyani sir joining as a key respondent to represent the Association of Healthcare Providers of India. Also giving a clear indication that we need to see that how the healthcare sector can take 3D technology seriously, and also to look at creating a module for POC going forward. So that's another initiative that we are with 3D Graphy. We are also looking at working on these lines. Furthermore, I did have an opportunity to also have Dr. Girish Rao and Dr. Manjunath Rai from AOMSI from their offices to also share their insights and inputs, and also the Indian Orthopedic Association. And so it was a very interesting day for us to connect with all the senior respondents in the helm of medical, representing each of their medical associations. Ladies and gentlemen, this technology is a game changer, and we all know there is a great potential going forward. It's not, you can't call it a future, it's already present, because this is making convenience in terms of the procedure may be in each of the specialization, and also making it comfortable for doctors and surgeons to get the right solution to the T in terms of what is expected, and also then to look at patient satisfactory index, which is very, very important. So I think a platform like these will definitely help encourage and also educate new aspirants and doctors and students, and also researchers and specialists from each of these specializations to get to know about this technology more, and then get involved in the process. More importantly, when it comes to research and material science, because now it's the time for creating new materials. So we have a consortium. 3D Graphy has actually been able to build as a consortium with doctors, surgeons, designers, material scientists, also researchers, and also professionals like you who are from the industry and various specialization, to come forward and get engaged and see how this technology can be made best. I mean, how we can utilize this technology to the core to benefit the end patients for sure. So that's the larger motto. And our motto this year is also democratizing 3D technology to benefit all. So today I have the privilege to introduce you all to a list of key respondents and members from the AOMSI. And let me take the privilege to invite Dr. Girish Rao, who is the Honorary Secretary, AOMSI. Doctor, thank you so much for your presence, sir, and thank you for your active support to actively be a part of this particular event. This being our 44th event, sir, and it's a privilege. It's been last 8 years in terms of promoting the technology and building various different platforms to engage. So it's a privilege to have you on board. I also have Dr. John Nissen, who is one of our key respondents. We've been working together for the last 8 years, and Doctor has been a great support, sharing his insights on the subject. I have Dr. Shiva also joining, who is an oral radiologist, coming with his perspectives in terms of how 3D technology can offer solutions, and also then Mr. Janardhan Venkat, who is a technology supplier of these products and solutions, and also Dr. Dinesh Jain, who is a maxillofacial surgeon and also an implantologist, who is joined, and they will be sharing some of their insights. Following them will be also Dr. Pranav Sankalp, who runs an organization called Lucid Implants, offering solutions for head and neck, and also other specializations that he's also actively looking at in terms of offering. So today would be a great session for all of you to learn from experts like them, to also register your thoughts in terms of how you can probably use 3D technology to the extent of what is actually what it is required to. So let me invite our guest of honor for this session. Doctor, thank you so much for your time and your thoughts, and then we will have you as our session chair to also take the course forward with the speakers to follow on the day. Thank you so much, sir.
Thanks, Shibu, for inviting me to be a part of this wonderful conference, 3D printing and dental applications and medical applications, through your platform, which you have been beautifully doing in the last 2 days. Today is the second day, and it was very interesting for us to come from the Association of Oral and Maxillofacial Surgeons of India to be a partner for this meeting. Although it's a virtual, I would love to meet people face to face and discuss a lot of things. I think it's nice to connect to the world through a virtual kind of thing, but nothing like actually being face to face in a conference. And I think probably COVID changed a lot of things, and it's shrunk the world. We are able to connect across the globe today, and it's very, very interesting the way in which we are sharing a lot of knowledge, cutting across specialities. 3D technology is something which I believe is definitely has been a game changer, right? I got introduced to this technology very early in my career. Been using this for almost about since 1995 or 1994 actually, when I was a senior house officer in the UK. My boss, Hugh Walters in Torbay, was a very, very kind of although an old-fashioned British surgeon, but he was tech savvy, I would say, and he would get us to do all the orthodontic planning virtually, and that's where we were mandatorily made to print models. We had to send it to London from Turkey, and then do the model surgeries. And then we started doing a lot of virtual model surgeries. And that's how my introduction into 3D technology started. And then having, fully trained in UK, I came back to India in 99. And I've been practicing this beautiful technology, which has made our life so much easier. And I believe that there is so much more for us to learn from each other. And that's where a meeting like this can bring a lot of different people together, right? I'm a clinician, and yesterday we had our orthopedic colleagues. So straight away we had two sister specialities, maxillofacial surgery and orthopedics, exchanging what they are doing and how they are basically looking at. And then it's so interesting to see the academia coming in. We had people from IITs and ISC. Both are premier institutes in the country, probably in the world itself, but doing some cutting edge technology, cutting edge research. And that has been, again, a game changer. And then it was very interesting in the morning session that we had two entrepreneurs who are really taking what is being done in the labs into reality and making a huge difference with this technology. So it's nice to learn, it's nice to interact, and more even nicer to collaborate. See, the thing is, once we start collaborating and putting ideas together, I think different kind of food comes into the plate, and I think ultimately it's the patient who is going to benefit with this kind of networking and this kind of collaborations. So I'm excited about this technology, and I must congratulate Shibu for really putting his heart and soul into this conference, right? It's not easy. I mean, we have organized a lot of conferences. I mean, for the last 25 years, we have been doing, I mean, I've personally been involved in running conferences. So it's extremely difficult to get really good speakers onto a platform like this. And, Shibu, hats off to you for the wonderful things which you
Thank
are
you.
doing.
Thank you, sir.
And I'm sure we are going to work together from AMSI and different organizations, and let's really make a huge difference. So let me not take much time and go into my presentation, which I'm going to start off in a minute. Let me share my screen. Right. As I told you earlier, I've been involved with this technology for the last 25 years. And it's exciting to see that more and more youngsters are taking it in a very, very big way. So, what I'm going to do is basically I'm going to share my insight into how this technology is transforming oral and facial reconstruction. Right. Why is reconstruction a necessity? I mean, as a maxillofacial surgeon, we do a lot of resections. It could be for certain congenital deformities, for traumatic deformities. There's so much of road traffic, injuries, and there is a devastation on the face. Or it could be a tumor, be it a benign or a malignant tumor, like these, what you can see over here, where we have to basically resect. And when we resect, what happens is there is a devastating morbidity, right? There is a huge impact on function and aesthetics, and that has a definite kind of effect on the quality of life, starting from inability to take proper nutrition and a huge problem with psychological impact on these unfortunate patients. So the next thing is after resection, we need to think in terms of reconstruction. And if you look at this young lady, she was covering her face all the time or this young man, he had a tumor and he would always cover his face and walk around in the society. And that's because he had a tumor like this on his face. Or look at this lady. Unfortunately, she had a resection done elsewhere and they haven't reconstructed. She is just 22 years old. Half the face has been mutilated, and you can see the sorrow in her face and in her eyes. And that's something which is not acceptable today in the way in which we have to rehabilitate and reconstruct our patients. So there has been a complete paradigm shift in the last 30 years in the way in which we practice our own profession. In dentistry, this is how we used to practice, and this is how we have modern offices today. And in surgery, this is how almost a century back or 150 years back, when there was no anesthesia, surgery was very barbaric, and people had to really pin the patient down before he underwent a surgery. And this is how we make our surgeries today so comfortable for our patients and so much more predictable. So there has been a huge paradigm shift in the way in which we are practicing today. And if we look at the way in which surgery has evolved, I think the world wars, probably for our modern surgery, gave a huge leap in the way in which reconstructive surgery started. And this is World War One, and this is a typical trench war, which you can see over here. And these were the trenches which were dug, and the enemy would shoot. So the face used to get blasted out, and the patient would die, or the soldier would die. Or if he survived, there was mutilating injuries. I mean, if the brain was blown out, then the patient would die. But if the bullet went bit down the brain, then the face was mutilated. And this is how they would shift these kind of patients from the front and into what were called as the reconstruction hospitals, right? And that's where Harold Gillis probably started reconstructive surgery. And because he was molding a lot of tissues from different parts of the body, it got the term plastic surgery. And along with plastic surgery, there were two very, very sharp dentists Norman Rowe, Kelly, and Kay. And these guys started the specialty of maxillofacial surgery. And that's how our specialty of facial-maxillary surgery or maxillofacial surgery started together with plastic surgery, and we started doing a lot of reconstructions of the facial skeleton. However, surgery is not new to India. We have had surgery for the last 5,000 years, and Shushruta is the god of surgery, or you can call him as the father of surgery. And in his book, Shushruta Samhita, he has very, very beautifully described reconstruction of the face. In fact, he's done so much of reconstruction, and the precision, even today, for the reconstruction of the nose is probably one of the best flap, and that's called as the Indian flap, right? The median forehead flap is what which we use, and this is typical. Even in Ramayana, if you go back into history or mythology, when Lakshmana chops off the nose of Shurpaniki, people like that have been reconstructed. And Shushruta has very beautifully described in his textbook, which is a masterpiece, and it stood the test of time, and you can see the same surgery being done. So if we look into the way in which we consider doing reconstructive surgery, it's basically to restore the form and function which is lost. And that's where we have to look at aesthetics, competencies, and then you need to look at function, which could be speech, swallowing, or mastication, chewing, right? So these are the principles on which reconstruction is done. And there is a ladder in which you can start off with reconstruction, starting from a simple skin graft to a local flap to a microvascular reconstruction flap, right? A free flap, what we call today, which has been the gold standard. So let me take you through one simple case. This is a young man whom we had to resect, and he had an aggressive jaw tumor. We had to do a bilateral maxillectomy, as you can see over here. That's the entire maxilla and the zygoma which we have taken out. And this is something which we are doing very, very often for the black fungus or the mucormycosis, which happened during the second COVID, the same kind of surgery which we had done almost about 15 years back. A typical reconstruction when you have a huge resection like that is what is called as a fibula microvascular flap. You can see the leg bone. There are two bones in the leg, the fibula and the tibia. And the fibula is not the weight bearing, so that's where we have taken a straight bone has been osteotomized here. You can see the way in which we have made it into a horseshoe. In the leg, we have placed the implants. That's the skin paddle, and you can see this is the artery and the vein still connected in the leg before we have actually disconnected it. And you can see the implants and the abutments over there. That's now transferred into the face, and the microvascular anastomosis is done. The peroneal artery is, anastomosed to the facial artery, and the peroneal vein into the internal jugular vein. And that's the kind of reconstruction which we were doing, or in fact still doing, which is like the gold standard. And you can see the kind of complete transformation which has been done for this kind of patient. A year down the line, when the bone which was osteotomized has consolidated, the implants are exposed, and that's where we are doing rehabilitation of these patients. That's the prosthesis, and that is this gentleman now who can open his mouth normally, who can chew, who can speak normally, and that's where we have done a phenomenally good job in terms of reconstruction and rehabilitation. So as I told you, the gold standard is this kind of surgery, but this has a downside. It's a long operating time. It may take probably about, anywhere from 10 to 15 hours. There is a donor side morbidity. We are taking the bone from the leg. And when you have a medically compromised patient, especially somebody who is diabetic or has a peripheral vascular disease, then it is extremely difficult. The other issue is the training is very extensive. You need to go through an excellent, rigorous kind of training to get this kind of research. In fact, for me itself, it took probably more than 10 years of training before I started doing this kind of surgery on a day-to-day basis. So what is that which we can do today? We have a lot of technology. Can we adapt this technology to make a difference in giving a better outcome than what you saw just a minute ago? And that's where, if we look at things which have happened across the globe in the last decade or two, there has been a huge disruption in our lifestyle itself, right? And disruption means which is transforming things for the better. And if we look at it, our regular SLR camera today has almost been replaced by a simple high resolution mobile camera, right? What we used to have maps, today you have GPS. An encyclopedia, where in the libraries we had such volumes of books, today you can get at the drop of a second on your phone on using Wikipedia. We had video libraries. Today you have Netflix, where you can just download. And probably in the future, nobody is going to own a car, and it's all basically either using Uber or Lyft in many countries. And that's disruption which is happening. So to get this kind of disruption, there has to be a thinking out of the box. And that's absolutely important, that you see things which others are not able to see, and you can see future. And if we look at certain disruptives which have happened, which are completely changing things, internet is one thing, augmented reality is something which is completely transforming, virtual reality, AI, blockchain, and drones, robots, and 3D printed technology is something which is a disruptive technology, right? And this is here to make our lives better, right? So the future of reconstruction is going to be 3D technology. The planning, it starts from planning. It makes life so much easier. And today, I have my colleagues who are going to talk about planning and how this is being executed in our day-to-day practice and where we can make changes in the future. And we'll also look at what are the pitfalls in this kind of technology. At the end of the day, there could be an infection because this is a foreign material. Acceptance is very, very important. And that's where we were talking yesterday on how these materials can be modified so that they can be repellents or antimicrobial kind of 3D printed materials which we can use, be it a scaffold or be it a metal. And that is something which is going to really, really make a difference. And if more and more people start using it, I think the cost would come down, so that affordability is something which is going to be a huge difference. So if we look at 3D printing technology, we have additive as well as subtractive kind of technology. So the old formative kind of thing, where we used to mix powder and liquid together and make a mold and pour it in a mold and get a cast. From there we came into subtractive, where you can mill, to now you have additive technology where you can sinter the materials in using lasers, and you can build anything using 3D technology. And that's the sequence in which we go from getting a proper CT image, then segmentizing it, 3D planning, designing it using a specific software, and then we send it to the machine where the manufacture happens, and that is sterilized properly, and we use this in surgery. So let me end up with a couple of cases which I've done, where we have had some complicated cases. This was a craniofacial tumor, which was involving the frontal bone, the ethmoid bone, and the base of the skull in the anterior cranial fossa. And her vision was getting disrupted. She was almost losing her vision. So we had to go in a combined approach with the neurosurgeon and a maxillofacial surgeon. That's the CT scan which we have done, and that's in the OT. You can see that's the model which we have used, which was extremely useful for us. After doing the planning on the computer, we printed this, and this is the planning which we had to do, where we were taking it out. And this is the area we decided which we are going to reconstruct using a PEEK. And you can see the way in which this is the material which we have used, PEEK over here. And this is where we have got the results like this. So from here, this is the kind of results which we had. In fact, for this, we had to send it outside. And luckily today, outside the country, I'm talking, I used to use a lot of technology from Israel, from Singapore, from Germany. This is in the last 20 years I'm talking about. But today, I'm glad that so many companies are doing some phenomenally great job. And I think it's time that people from different parts of the world will start sending their kind of planned software on to our machines, and we will be exporting it to them. I think that's where we should be looking at. Another young girl who had a first start syndrome. This is basically a hemifacial microsomia. Her mandible on the left side was deficient, and you can see there was no condyle. Only the coronoid is here. The posterior aspect of the ramus is missing, and that's where on the computer we have planned it. So we mirror using the right side, and the prosthesis has been made. All she was interested is actually a buildup of the lower border. So you can do it very precisely using the normal side, which acts as a control. So you mirror that and then you print it. And that's a titanium lower border of the mandible, which we have printed over there. And that's the one which we have fixed using a neck incision in the second neck crease. You can see very simply you can do this. And that is fixed with titanium screws. And you can see the post-op OPG, where you can see the angle. This angle corresponds to this. So you're able to define the facial features, and you can see you can give a wonderful result for this patient, and she is extremely happy. Another pathology which I would like to share with you. This young guy was a sportsman. He had an ameloblastoma of the mandible. You can see the entire half of the mandible completely eaten away. That's the destruction. Typically, I would be doing a fibula for this kind of patients, but he said, I don't want my leg to be touched because I won't be able to play football. He's a state player. So that's the CT scan. You can see the 3D print, the 3D sections of it. And that's the model which we have done. And you can see the way in which we have done a framework, right? And that was converted into a titanium. Once we had it, that's the prosthesis. This is what which is called as 3D printed patient specific prosthesis, which we are using it on a routine basis today, right? So that's the mandible which I've resected. You can see the cutting guides being used. This is something which has been a game changer for us. So the exact cut, you can see I've preserved the condyle over here, and I've put this guide over here. Using a fine reciprocating saw, you can make a cut. And because he was a young man, I decided to completely lateralize or remove the nerve completely from the tumor so that that could be preserved. And that's something you can channelize it completely, pull the nerve out, and you can lay the nerve inside this prosthesis with the graft material which you can put. That's the titanium 3D printed specific prosthesis. And you can see the post-op X-ray, and that's the CT, which shows the kind of reconstruction which we have got. So what I've done is I've placed some bone graft also in here, right? It's a combination of autogenous bone from the normal side mandible and some synthetic, and PRF is what I use so that I can actually place some implants into that. And you can see the contour which has come over there. And that's the kind of, intraoral closure. And you can see the kind of results which you can get. So I believe that 3D printing or 3D technology is a surgical game changer. So that's something which is going to have a huge impact for us. And it's got huge applications, be it in orthognathic surgery, where we can have already a pre-bent plate, and we know precisely how much of maxilla we're advancing or how much of mandible we are setting back. So precision is something, and you don't have metal fatigue in that. So that's something where you can do. If it is in cancer, you know where your cuts are. Or if it's a benign tumor, you know how your patient-specific 3D printed prosthesis is. And today, with mucormycosis from the Association of Oral and Maxillofacial Surgeons of India, we would like to have a national project where we would like to identify a lot of patients who have had facial disruption. In fact, a lot of patients, we have done a survey and we have seen that more than, almost about 3,000 or 4,000 patients are in a need to do, young patients who have good medical history where we can take up this 3D printed technology. We would like to rehabilitate them, reconstruct them, and basically be a game changer in their life. So that's where I think our Maxillofacial Association and the Prosthodontic Association are going to come together, and we're going to request a lot of philanthropists to help us so that we can take this as a national project and make a difference to all these patients who have unfortunately lost their facial parts, and that's something which we would like to do. So, in conclusion, ladies and gentlemen, I think 3D printed technology is a novel technology which is going to really disrupt the way in which we are practicing our resection and reconstruction today. It's got a huge advantage. It's got extensive applications, and it is like precision medicine, right? It's precision surgery today, and it can be predictable. The outcomes can be so much better than what we had to, really put our heart and soul into planning the whole thing. Today, with virtual planning, you can do so much better, and it can make it much more simpler, especially for the younger generation, so that they can adapt this technology and give better results than what is expected. And I believe that if a lot of specialties come together, right? Team stands for together, everyone achieves more. It could be maxillofacial surgeon, a prosthodontist, a plastic surgeon, an ENT surgeon, a general surgeon. It could be our allied specialties who are all coming in together, working with our technocrats, starting from software engineers to design engineers. And I think ultimately the most important thing is giving the best to our patients. Your patient deserves the best. And that's where collectively we can make a huge difference. And I'm sure in the lectures which we're going to take you through, we are going to show you how each one is bringing to the table their technology. And that's where we are going to make a huge difference. That's my website. I have a YouTube channel, Learn Maxillofacial Surgery. A lot of these videos are there. And if you're interested in seeing some of these, more than happy for you to send a comment and we can share it with you.
Thank you so much, Dr. Giresh Rao, sir. Thank you. I mean, it was so detailed and covering a spectrum of, the case studies that you have been able to do, and very complicated surgeries made so simplified, doctor. I mean, really impressed with the kind of work that you've been doing, and also from where you started, being in the epitome in terms of offering services with the technology. So we are so happy that it is definitely a game changer in terms of what this technology can do. And now let me also take the privilege to introduce you as a session chair, doctor, to also introduce the subsequent speakers to make their presentation. I'm sure everybody has something great to share as we progress. And towards the end, doctor, we will also have these inputs, which we will also take to also draw our conclusion, summarize it, also for a panel discussion, doctor, as per your time and availability. Thank you so much, sir. I'll open the stage for you, sir. Thank you.
Thank you. Thank you so much. Are there any questions, or shall we have the discussion in the end then?
We'll have the questions to the end, but I have people. 1 second. Yeah, we will take the questions towards the end, sir. While we will also have a panel discussion, I'm sure people would also be able to jot all these points one by one to then come with their inputs eventually.
Okay, sure. Right. I think the next speaker in line would be Dr. John Neeson. John is also a dynamic maxillofacial surgeon. He is also an entrepreneur. He started the 3D Sitars, which is a company in Chennai, and that has really made a huge impact already in a lot of surgical circles, both in the maxillofacial and plastic surgeons who have been using this company for using 3D printing technology, starting from planning also to patient-specific implants. So may I invite John to kindly come over and do his presentation.
Hi, good morning, sir. Thank you for the lovely invitation. I think after the master speaks, I mean, I don't know what more I am going to add on value now. Uh, but let me just share with you our experiences of working on 3D and what it has done and how it helps. So basically, this is to where are the applications and what can be done with 3D printing. That's basically what we're going to show. So my topic for today is basically going to be role of 3D printing technology in reconstructive surgery. Very similar to what Dr. Girish Rao said. So today, reconstructive surgery is going leaps and bounds. Thanks to mucormycosis, thanks to cancer, thanks to integration between departments, we are today seeing most of the surgical departments using technology. Gone are the days when every department would be on their own. Today, I've seen a lot of integration between plastic and maxillofacial, maxillofacial and prosthetics, dental. So there is a lot of coexistence that's happening today, thanks to technology. And today we are able to solve problems for patients which couldn't be solved earlier. I mean, even 10, 15 years ago, I guess we were doing the same kind of problems before, but then we would do two, three surgeries, we would repeat them, there would be a lot of trial and error. Today, all those are minimized. In the end, what does this do? It helps in patients having better lives, better faces, patients going back to their normal lives much sooner. And what it does to the doctor is that it helps him establish himself, make less errors, and in a market which is highly competitive, stand out. This is what the technology does. And I've had the opportunity of working with this for the last 15 years, as an individual, as a company for the last 6.5 years now. And I think the road forward is truly amazing. Uh, thanks to Professor people like Dr. Girish Rao sir, who's actually at the forefront, and it is a great pride for me as a secretary, sir, to to for somebody who can lead. You understand? Somebody who is there, who's leading the way forward, and for us, so it's very easy for us to follow. Earlier, no, it would be take me a long time for me to discuss and trying to convince the doctors, but today that's not the case. So technology has moved forward. So I'm just going to show you what and all we have done with respect to technology and how we've used it. I'm John, a maxillofacial surgeon. I'm the director for STARS, also the joint director for 3D Para, and a consultant in Apollo Spectra Hospital. This is science where the people would come and look into it. And today, science and technology have way gone forward. Like Sir said, today with the advent of VR, AI, and virtual reality, today a lot of things which was found difficult is made easier. And when we are talking of 3D technology, most of you would remember when we started, it was only about models. So people would come and say, I don't want 3D models. No, like, okay, is this just some 3D model technology, stereolithographic model? I still have doctors who come to us and say, I want the stereolithographic model. Those are only one small aspect of the 3D technology. Today, this has actually become changed and it is going on into much, much more different aspects in 3D technology, which I will just talk about it now. So I work on this concept, which is about 100-year-old saying, which says that if we all worked on the assumption that what is accepted as true is really true, then there will be very, very little hope of advance. So if we want to go forward, we always question what is present and then we try to say, can I make it better? Is there an opportunity for me to do this much better using technology? That's where technology changes. Okay. And like I said, 3D printing technology is just not one. Today we're talking with the Internet of Things. We are working in seeing how we can work with robotics, and most important is data. Today when I was talking with a few investors in recent times, we didn't realize this, but then okay, we have so much of data on our hands. So data is something which is very critical. So when we talk of reconstructive surgery of the face, you're talking of the entire visible part. Okay, every other or part of the body is also important, no doubt about it. But this part of the face, when we're talking, is extremely visible. So even if you have to make a small change, the patient would see it, and not just the patient, his family and friends would very visibly see it. And that in turn will either result in him being confident or being going into a depressive state. We have had earlier, we've had patients who had surgeries, and because of depressions, because they have lost their jobs, they're not able to go out in the forefront, a lot of issues have happened. Again, I'm saying thanks to technology today, all those is being minimized. I'm just going to give you an example of where or not we can use these applications. Exercise and trauma, we can use this a lot. I've seen a lot of applications in congenital today, temporomandibular joint or ankylosis situations with jaw corrective. There's a whole world of difference that technology is happening for them. And of course, pathology. Pathology has been there for a long time. How do you make a change a child's face from where it is to where this is? This is technology. All right. Now from here we can go on to this. I'll show you again how technology we used over there. Not just that. This was the person's face from this, which was on the news, again to here. This is planning. This is technology. I mean, this was not. This we were all just part of a small part of it. A large team. Again, this was an Aster. The previous one was from the Children's Hospital. So I'm just this example was a 10-year-old kid who came in with familial gingivitis cementoma. So the options that you have for situations like these are very, very limited. Imagine he's a kid. So what do we do? As technology, what we can only do is just see the defect and then try to only resect. The only probable option that the doctor could do is resect. Because let's not even talk of reconstruction in these cases. So when this case came to us, then I said, okay, when we have might as well resecting, why don't we even think of something called as reconstruction? So, but how do you do reconstruction? You need to reconstruct. You need to resect the part of the bone first, and then you need to come back, plan. Not possible at all. Okay. So again, this is because of virtual surgical planning and AI that we have. So we resect the part of the bone, and then we match it with a similar data. So this is where AI and data matches. We have close to about 7,000 sets of data scans with us. And so see the kind of information that you're gathering with them. So ran the whole thing based on a small AI program that we did, saw what was the best match, took the best match, and then started designing the PSI based on the data that we have. Because you have that, and then how do you check what you do? And this is all guesswork, right? So did prototyping on dummy models, and then shifted the same thing to titanium. Also gave the patient teeth, extracted it. See, this patient, guys, doesn't have any muscle there. All that he have after this bone, after the titanium, is only skin over here. No nose, no nasal passage, no oral cavity that we has got over there. Just skin on top, and then supported by the titanium framework. This is technology. I mean, we need to do a lot more on this kid. But then I'll tell you, this is where he was 6 months. It's almost been a year since we operated on this child. And things have done. So this is the team from the Children's Hospital. All credit goes to them. I was just part of the planning team over here. Mucormycosis. This is something which is changing in, and we get almost close to about 10 to 15 cases every month into our center, trying to see what can we restore. John, we are getting cases like this. How do we restore this? So a lot of things can be done with just 3D technology. You don't need to take bone from the leg, which is still the best choice possible. But what we have done is taken an implant, designed the implant in this way, not just designed the implant, but also restored him with teeth. See, what is important, we have a lot of people who design the implant. Unfortunately, if you do not design it correctly, what happens is you're not able to restore teeth. These are fixed processes that we're able to give the patient, and this whole thing was done in almost, I think, 3 weeks we took from the time we placed the implant to the teeth being done. We are trying now with, can we do it on the same day possible? That's where technology is, okay? And so this is the patient, and this is how confident he is after the surgery. That's the advantages of technology. Different designs there, just to show you the different designs possible with orbit, with the entire maxilla gone. Different kinds of combinations come to us. So we sit as a team over here, plan the whole thing. If not of technology, I'll tell you, this would have been a situation where we would have just had to give the patient a removable prosthesis, ask him to live his life with it, planned for plastic surgery. Today, plastics are not involved at all in this, unless until there is a soft tissue cover, there is a big defect there that we want to cover. And that too, most maxillofacial surgeons are doing it themselves today. So, designs over here where we're replacing the mandible and also trying to give off teeth. Okay. So, this is how technology has gone forward, and it is going forward. A situation where you have absolutely no teeth. This is a case which which is there with us for the last 4.5 years now. So removed the entire bone, and this was the 4-year-old design. So you can understand this. With studs over there, straight away placed the implant over there, took the impression, gave the patient the prosthesis, and it's staying for the last. So if somebody comes and tells you, I mean, technology is good, guys, but I don't know how long it will last. We have cases which are 6 years, 7 years old standing. Okay, PSIs standing, and this is how you change it. And not only just that you change it, you also replace the patient's lives. Okay, he go back. He's the only earning member of the family. So that's how the game changes are happening today with 3D technology. So into replace a jaw, teeth are being ready. And another case just where you just not need to use PSIs. Most of these secondary traumas that come to us today are, John, I want to do it, but I don't want to do full implants. I want to also replace bone, because whatever said and done, the PSI is only replacing function, form, and aesthetics. It doesn't replace biology. Biology is only with bone. Okay, so that's something which we need to understand. So a situation like this, when you have some amount of bone, rather than just trying to remove this off and throwing it out, what we did is using planning. We took the whole fragmented bone, we try to merge it across and see how far I can bring it together. When we reposition this, and then we think of once we repositioned it, then we think of making an implant. That's the design of the implant, and that's how the implant is being done. So this helps to stabilize the patient's existing bone, as well as create a whole custom made plate and screw which holds the entire thing intact. This is the big game changer. Facial asymmetries, virtual planning, and total joint replacement. This is something which only the best used to do perfect. In India today, with skill, a lot of training, and a lot of use of technology, we are trying to see how we can change patient's face at one go itself. Ideally, for a patient like this, what the norm would be is do an orthodontic surgery first, correct the patient's face, and then at a second stage think of a joint or distract the bone. Distraction used to be very popular. I'm still saying distraction is good, but cumbersome, inconvenience, a lot of things are there, not ideal indications for these. So what we have done with the technologies, we are able to see how we can plan to restore this patient's face, correct the patient's cant just by altering a few bones here and there, and then rectifying and replacing it. Just not correcting, we're also, once you stabilize and correct the cant, like in this was the patient's pre-op cant, this is where they are now, then you can start thinking, how are you going to stabilize this bone? That bone is replaced with the custom-made temporomandibular joint. This, for a long time ago, used to come from US and Germany, and it used to cost us almost anywhere between 1.8 lakhs to about 4 lakhs. Today, we are able to do it at quarter that cost. Quarter that cost. And like Girish Rao sir said, today we are now not just doing it for Indian clients, we're also doing it for international clients, where they're seeing the same kind of technology being used, the same material being used, and actually the software and tool is almost the same as is well universally done. So India is now just not limiting to India. We are now able to get products out to globally also. So this is the way the technology is. So we have the FOSA component, again made in India, the titanium, again made in India. All this today is made in India itself. And another situation here was a surgery where the patient actually had no face. I mean, there are no teeth in the anterior bone. So what we have done is we've made an artificial teeth, merged it together, brought the mandible forward, and then did a custom made joint. So when we do these kinds of counterclockwise kind of a surgery, we are able to see how much we're able to move the jaw forward. So all this is a little bit skill with a lot of with you cannot replace skill. So let's get that fact straight. Skill with technology is a game changer. Just technology, it's like giving a monkey a garland or a Mercedes Benz to drive, and it will just crash it. You understand? So you need to have skill. You need to have your theory correct. Once your theory is solid, then technology becomes a big boom to you. Okay. So this is how we designed it. We did a joint. We did a custom made framework for this, and the denture. So this patient is going to have the processes done on the same day as a surgery for him. Okay, that's how we are. So joint designs, cutting guides being done. So today technology is being offered as the whole section, and even custom made leaf 4 fixation plates. So you can avoid the concept of you trying to make your plates bended on the table. With this, you just have to open it up and place the plates over there. It is still a little cost is still an issue there. So, but with more and more machines coming in, more and more service providers coming into the play, cost is becoming a little bit more affordable. People are working on it. I mean, in our example, classically, when we used to initially start our PSIs, I mean, there used to be a lot of bargaining forth here and there. Today, I out of 10 clients, only one client actually bargains. 9 of them do not bargain. I mean, because costs are pretty reasonable and also justifiable because you're giving them some of the best products available on the market. So India is moving forward with different TGRs designs, like just to show you over there, and this is becoming a game changer for reconstructive surgery again. So uh, traditional workflow with defects, you had hard tissue, soft tissue, and hard and soft tissue. You had removal process. Today, all this your workflow process for pathology is changing. The workflow process for trauma is also changing. But also and done, this technology has its limitations. The limitations are you need to be very careful in case selection. This comes with surgery. Initially, I'll tell you from my experience, we used to take all cases. No, I said, yeah, we can do it, we can do it. Only after the cases when we used to perform this or when I got the feedback, then we realized that that case was not the proper case. So today, if I get, if we do about, let's say, we get about 100 cases that we get data over here, we reject almost 50 cases of it. And we tell them these cannot be done with customized implant, go back to your traditional way of doing it, or this is much easily done in conventional way of doing it. So you'll have to be very careful in case selection because one, the patient's paying a lot of money for this. There's a lot of effort being done into this. So if you do not have the right cases, then you'll end up with a failure. Number two is design selection. Every Tom, Dick, and Harry that has a company will say that he can do 3D printing. Okay, so be very careful with who you're going to give so that the designs are what you approve. In a lot of situations, even when we initially used to do, I used to have engineers with us. We still have, but then they would come up with this design and say, "This is the best design." No, I said, "This is what is possible." I didn't understand that concept till I started operating. Once we started operating for the last 2.5 years, and I said, I changed most of the designs that we do. So because what you see as an engineering component is very different when you come into the surgery as such. So design selection is extremely important. Doctors, you have to be involved in the design. So see it because then you are the ones who's actually going to use them. Number two, if the designs go wrong, what happens is there are a lot of limitations which happen in the manufacturing. Because manufacturing as a machine will just do whatever it prints. Okay, you give it, it will print. But if your design is wrong, then there's a chance of it becoming very thin in certain areas. It will break. You won't be able to insert it correctly. All those limitations will happen in manufacturing. And finally, skill. Whatever happens, like I said, whatever happens, you need to have your theory correct and you need to have your hands trained. If you do not know this, it will fail. I've had beautiful PSIs given to surgeons and experienced surgeons, and who have made a mess out of it. Basically, because not that they don't know theory behind it, but then when you use a PSI, when you use technology, there is a certain aspect that we go on with it. The PSI can all is adaptable till the design stage. Once you manufacture, the surgeon needs to change him or adapt him to the PSI. You understand? On the theater, once your customized implant is done, you can't alter that. So just about Stars. Stars is a company till 2015. We are a company of surgeons, dentists, engineers all working together, and we have seen we have treated more than actually 5,000 products, 3D products. Customized implant we have done right now. Actually, we are at 747 something. So every day there are 2 parts that are going out for printing. I mean, I truly thank God for where we are right now, and I still believe that we are only at about 10%. As stars, we have covered only 10% of the market. There's still 90% needs to be covered. We have close to 437 doctors working with us and 36 hospitals plus hospitals working with us. Those are some of the hospitals, and some of our work that came in the newspaper as recognition. Okay, this came in the Hindu paper, where this was a young doctor with mucormycosis was reconstructed and rehabilitated. This came in from Hyderabad, and this was in Sims Hospital where they had used our customized implant to replace one of their patients' defects, the first zygomatic implant. So not just PSIs you can even work on for mucor with zygomatic implants, but case selection is very important, like I said, and that's something what we do. And these are some of our awards, and I really want to thank Shibu John and 3D Graphy for encouraging us when we were actually nothing. Right from 2006, we've been working with Shibu, and that encouragement has always been good, and it has helped us have confidence and where we are right now. So that's it. So this is just a few cases of what we have done with reconstructive surgery. Hope it was useful. A lot more can be done. A lot more we have not shown. And thank you very much.
John, fantastic presentation. And I think the most important point which you said is, as clinicians, I think it's your moral responsibility to be involved in the planning.
Correct.
That's absolutely important. Don't expect an engineer sitting somewhere, in Chennai to plan for your surgery, which you're doing in Mumbai or in
True.
Kashmir or in Bangalore.
Correct.
So it's
Correct.
very,
True.
very, very important that you basically be on the driving seat. They are there to help you, but I think it's absolutely important that, because trimming these kind of 3D printed titanium is extremely difficult, and it can go wrong,
Correct.
right? You've already got the patient under anesthesia. A big responsibility is yours. So I think it's important that the planning is good. Virtual planning, have a couple of sittings and then do it, right? Thanks, John, for that fantastic presentation which you're doing.
Thank you.
I'm really delighted that you've done more than 5,000 cases so far, and I would like to see you doing 5 million cases. That's what we
Thank
would
you.
like to
Thank
see
you.
you, right?
Thank you.
And the fact that you're using AI, which is very interesting. I mean, in these kind of challenging cases, it is something which it's a challenge for everybody, whoever it is, any part of the world. I think it's something which is very, very challenging. And when you can bring in technology, you can match, the coordinates and then see which 3D skull fits into this one, and then
Yeah.
you've already got a ready-made thing. So that's something which is remarkable, and I like the innovations which you guys are doing. Hearty congratulations, keep it going, and I'm so glad that you are a maxillofacial surgeon and you're doing some wonderful job.
Thank you. Thank you,
Um,
sir.
Good. Moving on, we're going to have the next speaker here, another dear friend of mine, another maxillofacial surgeon, a very senior maxillofacial surgeon from Mumbai, Dr. Dinesh Jain. He was an entrepreneur from day one. I've known him for almost about 30 years, I think. And, he started using technology, and probably one of the first to bring in CBCT into India, and putting that planning in. So he brings a vast experience to the table. He was also the past president of the Indian Society of Oral Implantology, which is a big body in India, has a huge number of implantologists across the country, and he has done a lot of work. May I take the pleasure of inviting my dear friend, Dr. Dinesh Jain. Dinesh, it's all yours.
Good morning, friends. Thanks for the kind words, Girish. I'm quite feeling good about it. And thanks, Shibu, for giving me an opportunity once again to speak on this platform which you've created. And I think you've taken the torch right from the time when I met about 6 years ago
to the level where you are today, involving all aspects, not only of the medical as well as the various other fields. So I would like to talk a little bit about the dental implantology, which we started. Of course, I qualified as a maxillofacial surgeon, but eventually I took a training in the. Is my screen visible? Fine. Yeah. Okay.
Yes.
Yeah. So I would like to talk a little more about the dental implantology. That is what I started working on when I, of course, was trained for dental implantology as early as in 1991. After, of course, getting trained in implantology, and then we realized that we were placing implants, but we were unable to restore them the way we would have liked them to be done. So after placing a lot of implant, then as time grew, we realized that unless we have a better planning modalities, so that's where, as Dr. Rao said, we invested into the CBCT. So CBCT was a game changer those days. Of course, I'm talking about the 96, 97. And from there onwards, 96, 97, of course, we got into a small little lab. And then as the technology advanced, we invested into many things. I will share my thoughts of how we involved ourselves into making our day-to-day life in implantology much better. So I would suggest, technology has changed a lot of fields of dentistry and lab processes. I make an effort to see how we have actually involved ourselves. And of course, we have not been financed by any of the companies or corporates. I created my own small little enterprise so that we could take it forward without any forces to derive anything out of it. So we always thought of global and seen how we could act on a local way. This is one of the inspiration which I've always seen, the art of seeing things which you could not see at that time. And if we can visualize that, you can always put it into practice. So digital adaptation, as we started it, some of the advantages which we had were improved efficiency, cost and time, simplicity, accuracy, and high level of predictability. You can not only plan that and predict that, but you can always share with your patients or the seekers who want the improvement in their looks as well as the chewing efficiency. Basically, I'm talking of the oral cavity. So you can discuss, you can plan it, and you can discuss with them what the end result is going to be. Now, this is how the adaptation cycle has been. So some of them were early adopters, a lot of people joined later on, and that's how I think we are in the space where the majority of the people are in this process. So to begin with, I think we started putting the patient records and management, patient education, dental x-rays, lasers, etc. These were the digital inspirations in the beginning of the 90s. And then, of course, a lot of things changed. And we got into what is called intraoral scanning, which would be important for acquisition of digital data. The laboratory scanning of models was one which we started much earlier before the intraoral scanning. Cone beam imaging started at the same time, which we, of course, try to possess all these so that to make the day-to-day life much more simpler, not only for us, but also offering these services, because all these technologies did cost a lot of money. So we had to involve a lot of others who could seek, and we could constantly innovate. So I'll take small little one by one all these topics. And these are the intraoral scanners which are available. We were earlier taking the impressions with the impression materials. It could be alginate or it could be the rubber base. But with the intraoral scanning, the digital workflow could start immediately. This is one of the device which is being used for intraoral scanning of data. This is how it works. You can see there are two windows. One which I am facing on my camera, or the intraoral camera is facing the oral cavity, and the other one is what we are recording. And it offers a lot of features which makes it very easy for us to see the accuracy of the data, see whether we have been able to record it completely. You can plan a small little crown or a bridge, and you can send it for the shade batching and various things which earlier we could not communicate with the lab. So this particular feature of the intraoral scanning device, in fact, the latest thing is that where we can even if you prepare a tooth, you can prepare a temporary immediately, or you can deliver a crown within about next 12 to 14 hours. So that simple it has become for us to work. So we did scanning for one of the 4-year-old kid to understand, as you can see, and we could do this for a 4-year-old kid as well, which earlier was very difficult for us to complete the or taking the impression. The laboratory scanning of models will actually, this was a device which would, if you have taken an impression and you want to follow the digital workflow, it would actually make it easier for us to send it to the lab. The lab will digitize the models and then the workflow would start. So this is the digital, the scanning of the models by a 3D scanner, which more or less most of the laboratories have adopted this in the present day. So most of the laboratories are also following the digital workflow. The digital data, either we send it to them from the intraoral scanner or otherwise they digitize the models and then the workflow starts. You can also design, once the digitization has happened of the models, you can design, it could be a crown and bridge, it could be an implant related prosthesis, it can be easily done. And there are various softwares available. The softwares are so exhaustive that you can actually plan your different implant systems as well. Their abutments, the fabrication of the abutments, different situations, positions. I'll show you through some of the cases how it could change. The cone beam imaging is another area which we have worked on. So taking a 3D digital data for us to do virtual planning of the cases, and the virtual planning would help you in placement of implants, or in fact, including the maxillofacial prosthesis also can be planned with the help of different softwares which are available. So you can see an impacted T3D video. Anyway, it's not, the video wasn't really. So what are the other areas where we can work? Smile designing, shade and contour matching, final prosthesis aesthetics, all these can be incorporated into the digital workflow to make our work easier. In fact, to be able to discuss and plan with the patient's involvement as well. So dental implant planning can be made. You can have, as you can see here, the planning can be done. So we are planning here those 2, 3, 5 and 4, 3, 4 and 3, 5. Your implant virtual placement can be done, followed by fabricating a guide. The guide can be utilized for exact placement of implants, the position as well as the direction of the implant, very important, keeping the bone in mind, and the final outcome of the prosthesis. So very simple, you can print this guide with small, the printers available nowadays, which are not very expensive, and you can do it probably in the next few hours. These are guided surgery platforms which can all be used for placement of the implant. So as you can see, the guide has been placed in the mouth, and the implant which has been planned with the help of a guide can always be placed much more easily, more precisely, less cutting, less damage, and no nerve cut or anything, because you've all planned keeping all that in mind. Now, this is how the virtual treatment planning can. This is one of my case which we have planned a full mouth lower implant placement. So the patient had 3 teeth, and we planned all these 6 implants in the mouth. You can see how the guided placement virtually has been done, followed by fabrication of guide, and then fixing those teeth or fixing those implants, and then planning the template fabricate. So this is another case where the smile designing can always be done also. This is for the big time aesthetic area, which is software driven smile designing. You can fabricate a template based on this, and that template can be used to fabrication of the laminates or the crowns intraorally. All the procedures which are, or the parameters which are required to be followed can be utilized in this digital planning. This is the guide assisted implant surgery. The CAD/CAM applications, this is of course earlier my colleague talked about the subtractive and the additive processes. This is the subtractive, where we use the milling machines to fabricate it could be the titanium bars, or it could be the prosthesis for the crown and bridge, so on and so forth. There are many applications. Then more and more applications are being added, and this is a subtractive application. You can mill either a metal or titanium, and precision is very good. You can also use the additive technology. Both the options are available. These are 5x milling machines, so you can get the contouring, etc. also. These are the resin printing solutions can be offered with this. So you can build, including the prototypes or the models, as well as you can print your guides. You can print your temporary crowns. You can print your temporary bridges. You can also, in fact, we are working on long-term bridging and the temporary crown or the long-term crown solutions, which we will be able to deliver to the patients within about 4 to 6 hours. And all that can be completed within one visit dentistry. So this could be another way. It could be a game-changing for one visit dentistry. So this is the additive. You can print the models. You can print, in fact, for the training purposes also, it can be useful in a lot of areas. So you can see the crown being prepared, or a guide fabrication, or many applications as more and more softwares are available can be used. In fact, one of the things which you would have noticed is that the fabrication of this is the metal printing. I'm sorry, I'll just talk about that. This is the metal printing, which can be used for precise fabrication of the implant-related prosthetics, as well as regular crown and bridge. It has changed the way we would practice the dentistry, or the earlier ways of fabricating the prosthesis, which would be not very precise. There would the available options that we had were there, but there were a lot of areas which could create where the ill-fitting prosthesis could be, So with this particular procedure of 3D printing, we could be able to improve the fit of the prosthesis, the snugness. This is the video which shows how the printing happens. So you have a platform on which a number of crowns or bridges can be printed, and it's a powder bed. What you see every time the recoater brings in a new layer of powder onto the existing, and then with the help of a laser, it does the welding of the next layer. Each layer is about 50 microns, depending upon the accuracy that is required, and it gives us an accuracy of 5 to 20 microns, which is very, very high precision. The crown bridge prosthesis, which requires a very snug fit, we achieved with this. You do not have to reduce the tooth as much as we used to reduce earlier, 1 to 2 millimeters. Here you can work with very less of crown structure reduction, and you can get a very precise prosthesis. So a lot of advantages in this. Weight of prosthesis, you have a very big prosthesis. So this is how the metal sintered crowns, as you can see the fit of the snugness on the model, which has been sectioned to show how snugly it is fitting. There are different materials used: zirconia, wax, PMMA, bioresin, metal, titanium, and the list is exhaustive. More and more materials are being used for the implant as well as the maxillofacial prosthetics. We have, in fact, people have been working on to where the organs can also be printed. So it's an ever expanding scenario. I'll show some clinical situations which I have been doing it. So this is a complete digital workflow, how you could follow either from a lab to the end product, or you can take an intraoral scanning and then go through the complete digital workflow. So I'll show you a few cases: implant supported screw retained mandibular replacements. Now this is a case where you will notice this is a CBCT of one of my patients, where you can see in the anterior the 2 teeth missing, anterior 2 teeth missing, and the bone available was very thin. But with the help of a guided planning, we could place the implants in a very precise manner in that small, very thin bone, and you can see the post-op X-ray with the implant placements. And then we had to work for the prosthesis. Depending on the availability, this is how we could place the implant. We did not have the optimum positioning, but we could plan still this into a digital workflow. As you can see here, this is my digital planning. We have still not given the prosthesis, but this is what we have planned: the number of teeth. The screws, which in one of the picture you can see is coming outside, has also been transformed to or changed to come into this was a trial prosthesis we prepared in a PMMA, and this was given to the patient for them to see and check if she likes it. And the next level, we transformed this into this is how it was in the patient's mouth. We could do the corrections. After doing the corrections, it was actually once again sent to the lab, where they could precisely adapt the same thing into the patient's mouth, and then we transform that into a metal printed prosthesis. You can see the planning of the prosthesis. This is the metal work, again tried in the mouth, and then the final prosthesis, as you can see in the mouth. A young girl, after doing this with those screws coming inside, she was very happy, and there is a follow-up of this particular case for last more than 6 years, and she's been doing phenomenally well. So this is from here to here. We could bring her, and you can see the looks or the aesthetics, which was very good. That's all because of the technology. Yeah, this was a resin printed bridge for one of my patients in the anterior segment. He had only 1 day, and these implants were placed earlier. He was wearing a flipper for some time, and then he came in the morning. By evening, we printed the resin denture, and he could leave the same day. Of course, it was changed into a metal printed prosthesis later on, but then he had sufficient time at that time. So this was a resin printed bridge which we could give it to him. This was another resin printed primary zirconia milled permanent. The gentleman had a very unique problem. He would not be happy with any of the prostheses which were delivered by my predecessors, maybe at least 2 or 3 of them. So then we worked on him. We gave him a digitally planned prosthesis, and we tried to tell him to try it out. All those corrections which he wanted, we made it, and then we made a final zirconia bridge for him, which he could see. He himself was an engineer, and he could see that it was actually planned, keeping in mind his requirements. He had no reason to not agree to that. So it was really, to be honest, more of a changing his mindset towards what he wanted, or he had a lot of ideas in his mind, and we gave a shape to all his ideas to get a prosthesis, a good prosthesis for him. There's another case I will show you for customization of abutment. So whenever we have the stock abutments, we have to use them the way they are, and they sometimes may be not suitable for proper positioning of the final crown. Sometimes there could be insufficient occlusogingival clearance or very large clearance, where we will have to adjust the height of the abutment. Your implant could be apically placed. The available gingival height in the abutments may not give the required length for you to have a proper positioning. So you can actually keep a less of an inventory, and there you can plan your abutments depending upon your requirement, which suits you best. So these are the terms which are used in. Of course, this is a little more technical. These are the scan body is used for scanning the position of the implant. The design software could be 3Shape, Dental Wings, Exocad. Milling strategy and softwares are used for if you have some undercuts, etc. Then you require a proper milling strategy to mill an abutment, and so on and so forth. So this is one case which I will show you, where you can see the clearance was very limited, and you can see the position of the abutment that we have planned, and this was actually placed in the patient's mouth with a screw retained prosthesis, which gives you a much more advantages. This is another anterior case where you can see the height of the gingival height of the abutment, which we have printed actually, and which could accommodate the implant which was placed immediately post the extractions, had to be placed in a position which could be more suitable. And this was placed, and after placing, we realized that the stock abutments will not fit in precisely, so we had to customize this particular abutment. And you can see that this is in the mouth, we're being checked up, and this is the final prosthesis from here to here. The person was a smoker, and we could make the final result, which was, we couldn't distinguish between his natural tooth and implant supported tooth. This is another case where we have 2 anteriors missing, the lateral incisors, and with the proper planning, digital planning, we could give him a fantastic solution. This is, of course, my office, and this is one case I will show you maxillary guided implant placement. There's a lot of noise in the background. I don't know, Shibu, what could be there? Hello? Hello. So this is one case I will show you of guided maxillary implant placement. This is a planning stage. We plan to place 6 implants. This is after the placement in the oral cavity. The implants with the gingiva formers, the impressioning, and then the prosthesis which was printed, and this is the final result. what we managed to get. Now, all this would not be possible by a freehand placement or a freehand or the with the ready-made abutments which would be there. So we had to plan this as a one-piece prosthesis, and the patient has been doing well for quite some time. There's one case which is being done by a friend of mine, and full mouth rehab, both the upper and the lower teeth, the upper and lower jaw, which is like 6 implants, 8 implants in the upper jaw and the 8 implants in the lower jaw, very strategic positioned implants, and then a complete planning with the digital. You can see the scan bodies to get the exact position of the implants, the trial with the jig trial with the resin, and then we would send it through. So in the virtual articulation, the dentures which were planned earlier for the exact positioning of the teeth, they were scanned, and that scan was used for a precise planning of the upper and the lower fully fixed prosthesis. This is the cutback. So this is how the planning would be in what you see. And after the cutback for metal printing, for creating the provision for the ceramic placement, you can see this, the screw channels which are being highlighted with the help of those screw channel openings. This is after the metal printed prosthesis which was there, and then we had to do the layering of the trial, some corrections, etc. if required, was tried in the mouth, and we could make some corrections. After that, we put it for the ceramic application, and this is with the opaquer, and then the ceramic work or layering was in process. This is all done in one lab where, you know, the printing and the planning and everything is done under one roof. Of course, a lot of involvement of workforce, but you can get really very good results. The final prosthesis, and in the mouth, the screw channels, again a screw retained fully fixed prosthesis in the patient's mouth, and you can see the precision that could be achieved with this kind of a digital planning. And this is the post-op OPG. The fitting of the prosthesis can be checked up, very precise, and a good follow-up with these patients is good. So this is how things have changed. So this is one case I would like to show, if I can, if the video works. So this is how the ease of placement of a prosthesis. So So these are futuristic 3D bioplotters. Again, there are a couple of them which are installed in Nagpur, and we've been trying to see if we can really get some, so we can have addition of maybe even with the maxillofacial work. It could be very useful in implantology. Wherever you have deficient bone, we could have bone which could be addition, which could be planned as per the requirement, and which would be held by the softwares, which precisely tells you what bone requirement is, and if it could be printed, we are looking forward to those areas. So just to conclude my presentation, science is nothing but trained and organized common sense. As I can see, technology in the hands of great teachers can be really transformational, and that is what we are all working toward. With more and more AI and artificial coming in, I think we would be able to achieve still better solutions in the time to come. We all have to. This is my facility, which is available in Bandra. The only reason we started with this is because it was a problem which I was facing, and I could foresee that a lot of other people could also be facing that. And so we have created a team of technocrats we could work with and understand our requirements very well. Whereas I put myself still 95% of my time into the clinical dentistry. So I have a complete combination of CBCT imaging, clinic, CAD/CAM lab, and all. We would have been. I could say that it was my own figment of imagination, and I could see the reality happening. That's my laboratory. Some pieces of them, and one who sees the invisible can achieve the impossible. So, if we can see what we need to do, is what we can achieve. Thank you.
Thanks, Dr. Dinesh Jain, for that wonderful presentation. Seeing the full arch rehabilitations being restored so easily is really a game changer. And that's where 3D printed technology is making such a huge impact in our day-to-day lives. I still remember when, the concerns we had was when a lot of international patients come, you are in such short, spans of time to do the restorative bit. It's easy to replace the implants, but my prosthodontist used to, struggle sometimes because when it comes from the lab and you have the metal trial and the bisque trial, you have issues with that. And today, to see the way in which technology has been used so that you can get a predictable outcome, which is not just predictable but can be a better outcome, is something which Dr. Dinesh Jain has shown so beautifully for our implantologists and maxillofacial surgeons and general dental practitioners also who are doing this. And it's a pleasure to use these technologies which can make our lives so much easier. Beautiful presentation, Dinesh. Really enjoyed listening to you. After a long time, I'm listening to you, so it's really, really heartening to see you in full form again. Thank you so much. Moving on, before I invite the next speaker, I would like to request there's someone who has got their microphone on, and my plea is it disturbs the speakers when they are doing such wonderful presentations. Please put your microphones switched off so that we can all listen and enjoy the scientific deliberations. Only the speaker will have his microphone on so that it doesn't disturb any of us who are listening to this beautiful Sunday morning presentations. I would like to now call upon the next speaker. It's from the industry. We have Doyen, Mr. Janardhan Venkat, who is the General Manager of Reddington India Limited. He has been in 3D technology, both in supplies and in service industry for a long time. A good friend of mine, and he is going to take us from the industry perspective how 3D printed technology is helping clinicians and labs essentially in our day-to-day practice. Dr. Venkat, it's all yours. Thank you.
Thank you, Dr. Girish. I think we had three great sessions, one from Mr. Girish and Mr. John regarding this maxillofacial applications. And Dr. Dinesh also has briefed about the transplant part of it. So they all spoke about the 3D printers and the technologies which is really helping them to ease their work, even though the skill is very critical for this kind of applications on this. So let me share my screen first and then I'll start with my discussions. Hope you're able to see my screen and hear me.
Yeah, yes, we can see you. Please go ahead.
Thank you. So I think the technology is playing a major role today in basically really driving these treatments, especially on the maxillofacial as well as the implants. I think Mr. Dr. Dinesh has also spoken about how the polymer as well as the metal 3D printers are helping them. And Maxillofacial is more of a 3D printing using metal, the transplant. But again, they're using polymers for basically for the studying the case, planning the surgery. So a lot of applications are there for 3D printers in the industry. So being a person with Reddington for the last 20 years, dealing with 3D printers of various technologies, I'm not a doctor. I haven't done any surgeries, but still I feel that we are providing the technology for these doctors who are doing exceptional job in treating various kind of issues with various patients. Now, let me segment this presentation into two factors. Number one is there is a need of really democratizing 3D printers and really taking them into a production environment where there are areas in dental where we need mass production, and there are areas where doctors and clinics need their own setup to really treat their patients as per the volume they have. So I'll just segment, and I will be speaking on the sustainability of this business of these 3D printers, how you can engage and how you can choose the technology which is most suitable for the specific applications. So before I get into the real discussion, as a company, Reddington, it's a 62,000 crore company. Driving the digital transformation across industries with various number of products. We have almost 235 plus brands giving us supplying the products. We are in the distribution business, and our distribution happens mostly through our channel partners. We have around 35,000 channel partners today who is interacting with us on a daily basis and really taking our solutions from the OEMs to the real users. So if you look at our interest is basically on IT consumers, IT enterprise and mobility. And also we have invested a lot of energy and time in building up the emerging technologies and bringing the various latest technologies into the Indian market, whether it is 3D printing, whether it is the digital printing or in 2D, where it is basically on cloud services, solar. So these are the emerging technologies our organization has invested on. And today, in the last 12 years, if you look at the Reddington 3D division, is serving the 3D printing industry. And what we carry today is basically there is a spelling mistake of high volume production using HP and the metal using desktop metal 3D printers with the latest technologies which is emerged in the last 4 or 5 years. And I think Dr. Jain was referring about Envision Tech. He has shown a lot of images of the printer he uses, the Envision Tech. That Envision Tech is currently taken over by a company called Desktop Metal and has been renamed as eTech. So whatever we speak about eTech is the old technology of digital light processing, which Envision Tech was bringing in. Company hasn't changed, only it has been taken over by the Desktop Metal. It's a US-based company. So we carry these two products as a distributor for these two products. We are the exclusive one for HP, and we are a platinum partner for Desktop Metal in bringing out the metal 3D printers as well as the Envision Tech or eTech polymer printers. So if you look at everybody is different, every case is different for you, and every digital work you do in a 3D printer, it has to be personalized, and it cannot be a what you call basically into a mass production or a batch production. It is basically a personalization what the healthcare industry wants, and the digital manufacturing or 3D printing is going to play a key role. Mainly because the industry is moving towards personalization. You want ergonomic and lightweight devices because you are all speaking about whether it is maxillofacial, whether it is dental. These are all the parts which is aesthetically has to be very important, and lightweighting is also very important. And all the doctors, what they need is the design freedom. And when you want all these three, the digital manufacturing or 3D printing is the key solution for you. And that is a technology which each one of you will be adopting and you are already got adapted to. So if you are looking at a big leap, so if you look at the Indian industry, there are a lot of dental clinics who has implemented very effectively for the transplants or basically for the maxillofacial applications. We have started using digital printers, and still there is a long way to go, and we are going to speak about this. So my focus, as I told you, let me start with the mass production, which is required, the mass production requirement, which is required for this kind of clear aligners, for your correction of your teeth and the geometry. So we are speaking about the clear aligners. This is going to be a mass market, Today the braces are getting replaced with this kind of clear aligners, which is much more aesthetic, much more easy to manufacture. And what we speak about is we are seeing that an organized it is getting to be an organized segment today, and mass production is required for this kind of segment. So when you speak about mass production of this kind of this thing, so it might be personalized designs produced in masses for various customers together and make it as cost effectively as possible. So when you want this technology to be cost effective, we need a 3D printing technology which can provide you more parts in one job to make sure that you are saving money on that, and there is enough throughput coming out of the machine. And should be the technology should be sustainable, the business should be sustainable for you. Then you need the printing to be much more faster than what you have seen as the point-to-point 3D printing technologies like SLA or SLS, where the laser beams goes and sinters each and every point and gets you the part. It has to be much more faster. The throughput has to be much more better, and the production cost and has to be much more cheaper. So to align these are the three key factors which really driving the future of 3D printing, because people were reluctant to move on to 3D printing, especially in the manufacturing segment, mainly because of these three issues. One is the part quality, then is the throughput, and third one is the cost of production. So what we are speaking about is a technology which is going to give you all the three and can be effectively used for the 3D printing operation to make 3D printing much more sustainable. So our focus is basically to get you the maximum throughput at a higher speed at a lower cost. So we have the technology which has come up from HP in the recent past, almost 3-4 years back, where we speak about as multi-jet fusion technology. It is a technology which is something similar to the SLS technology. The common thing is it uses the powder. So we use the nylon-based powder to really create the parts in the nylon material. So compared to SLS, where the laser goes and sinters each and every point, as Dr. Jain spoke about the metal. Instead of a metal powder, if you're using a polymer powder, the same technology we call as SLS in polymer, where it prints, goes to each and every point, sinters or fuses that powder there, and just get your job. So the moment we get into a point-to-point sintering process, that process is going to be slow, and the throughput, as the number of parts increases on the build, the time taken to be much more. So what we are speaking about this technology is a layer by layer transformation which is happening. So instead of using a laser, we are using the thermal energy like a polyjet machine, where we are going to spray something called a fusing agent. Wherever the fusing has to happen or wherever the plastic has to be really sintered, that area we will spray the fusing agent, and that fusing agent, when applying the last mile energy through a print head, that area will get fused and the part is getting generated and the next layer is generated. So in a split of a second, rather than getting into part by part construction, we are creating one layer of fusion and the next layer is managed next time. So likewise, this technology can give you predictable delivery time. So in 10 to 11 hours, the printing job will be completed, whether irrespective of whatever be the number of parts for a given height, the full height of 380 millimeters in the printer, the job will get completed. It is assured that it will take only 10 to 11 hours of printing. And as the number of parts increases, since because of the high reusability of the material, so when I use the powder, the next job I am using only 20% the new powder, 80% of the powder which has been used in the last job is getting recycled along with the 20% new virgin powder, and we are making as cost effective as possible. And when I make more parts, the time is going to be constant, and the throughput will be much more for me to really manage with. So if you look at the right side, I have shown you how we align these parts together, and we will be able to stack it vertically, horizontally, put maximum number of parts into the build job and get these parts done within this specific time of 10 to 11 hours. So that is the technology what we are speaking about. So if you look at orthosis and prosthetics in terms of creating dentures for clear aligners, this technology can give you the maximum throughput within the specific time or a fixed time at a very lower cost. So as the number of parts, the time is lesser, you can do more jobs in the printer, which will give you more throughput, as well as your machine is getting utilized maximum. So this is the technology what we speak about. And just I'll show you one video which is going to explain you how the technology works. So what we speak about is basically the strength of this machine is the production capability, and it is not just a prototyping machine. It's a 3D printer which can help you to produce strong, durable nylon parts, basically for your production jobs. So if you take a typical example of a denture, so if you are considering almost 50 moments required or dentures required for a patient to really do the correction in 25 stages of the upper and lower taken together, in a year, this machine can produce more than 11,000, can attend almost 11,000 patients per year. The productivity of this machine is so high that almost 650 jobs can be done per year, and these 650 jobs is capable of producing more than 5.5 lakh modes per year. So the strength of this machine is its speed, its durability, the throughput and the scalability. Mainly when I speak about scalability and the throughput, this machine is designed in such a way that 3D printer is designed as a separate unit. You have the processing station, which is basically taking care of powder handling, is taken as a separate unit, and build unit is the interface between the processing station and the 3D printer. So if you have multiple build units, this 3D printer can work 24/7, just producing parts, and you can fill the powder from the processing station in your build unit, insert it into the 3D printer, get it printed. Once that job is done and once the job is complete, you take out the build unit, keep it for cooling, and insert the second build unit, start working the job. Now, if you want to really enhance this, You can keep adding printers. The same processing session and additional building units and printers can really help you to scale up the result. So with a lower investment, the scalability is much more higher in this case. And the moment it is basically meant for a high volume production. So when you speak about organizing these kind of clear aligners into this, let us see how the workflow happens. So when you have, as I think Dr. Dinesh just talked about the process where he uses it for the implants, somewhat same process where we use 3Shape or other 3D scanners, dental scanners to scan the teeth and get the dentures ready by getting it printed. Take the scan images. Then on using the CAD softwares, you will be able to do the corrections at different stages and create the mold out of it. And that mold designs are transferred into the 3D printer for getting it printed. And once the print is completed, what you do is you have to do some sort of post-processing in terms of bead blasting or something of the kind, where you can really make it clean and take it in a thermoforming machine. The thermoform machine can be a standalone machine which can give few parts, or it can be a production. This thing like Hammer, a German company called Hammer, they have a workflow. They have this is basically a printer which can take care of the complete workflow, including the laser cutting of these basically the clear aligners. So if you look at the workflow, we can have a factory kind of a setup where mass production of these dentures and aligners can be made, and this is what we look at as the option for implementing this kind of technology in clear aligners. Now, if you look at the implementation, we have a company like Smile Direct who has done it really with, they have currently used more than 50 3D printers to produce parts for the worldwide requirement in terms of clear aligners. Let us hear from him how he works on that. So, Smile is one of the pioneers in this market who is producing these clear aligners in volume, and they have multiple ranges of it. If you look at the time taken for this printing, so if I'm going for a fast cooling, printing job is almost 11 hours, as I told you, and there's a cooling time of 9 hours. So, in 24 hours, one batch of almost 880 dentures, or probably if you are taking 50 this thing, so you can have that much of patients' dentures ready within 24 hours time. And because of this huge volume of production which is going to happen in these machines, this machine is going to help you to get these parts at a cheaper rate, namely because the material cost is low, the production, the per part, the production cost is going to be low because of that. And since you are using this machine to the highest level, and because of the throughput what you are going to get it for your investment, the per cost of your investment per the denture is going to be the cheapest. So looking at these two parameters, you can democratize this clear aligners market in India by producing these dentures at a very low cost. Today, if you are looking at any resin-based production of these kind of dentures, this is going to be at least 4 or 5 times costlier than the technology what we are offering to you in this mass production environment. So this is something which we have in our stock for you to really get into the clear aligners market. And so it is not necessary that always I have to go with a full height job. If I have some critical works to do, or if I want to optimize my production, you can also opt for smaller height jobs, whether you can typically, if you look at 200 parts, if you are just creating 5 layers of this dentures and for a height of 840 millimeters, or 84 millimeters, to almost the full height job. So if you are able to reduce the height and print the multiple jobs, you can really increase the number of jobs which is getting printed per day, and the delivery will be much more faster for you. So this is the way you can optimize this production of these clear aligner dentures, and thermoforming can also get automated using this kind of machines like hammer and all this. So we offer the complete solution in terms of design, offering the software support or the scanners or basically the printers and the post-processing thermoforming equipments also we can discuss about, and we have the right solutions to offer to you. On this clear aligners, as I spoke about the scalability, almost 40 dentures are getting aligned in one layer, and such layers, almost 22 layers, can get you the 80 parts or done in one single job. So that is what about the clear aligners. And we also have the software supports from Materialize or Qton, who's basically an embedded 3D nesting solution. And we also provide you some support in terms of softwares to manage these jobs together and really control your workflow in terms of production. So this is what we speak about this, and getting into the eTech or Envitech solutions from Desktop Metal. This solution basically to generate you implantable material, the plastic the materials which can get implanted also, and it also gives you the soft soft surface finish and the accuracy which is required to really manage this kind of workflow. So if you look at the solutions which we speak about, we have the partial dentures, surgical drills, all this we have suitable materials to really taking care of each and every application, the maxillofacial or basically into the dental industry. And this is another solution which is very commonly used, and I think in India also a lot of dentists are using this machine. So if somebody is looking at setting up a facility within their clinic and really try to do this kind of applications in-house, these are the solutions which will be the most suited solutions for you. So with these kind of two solutions on the plastic and on the plastic for the high volume production, as well as for this kind of critical jobs, you will be able to provide you services upfront. So this is some examples of materials what we have. We have FDA cleared materials, which is very much used in the dental industry, and we have the implantable resins also, which is basically can be used on this. So we also, from the Envision Tech, I think you had seen the images of this printer in the last presentation by Dr. Dinesh Jain also, where these bioprinters are basically helps you to recreate tissues or skin or bones, whatever you wanted. You can really recreate that using these bioprinters. And this is an emerging technology which is currently used extensively in the research purpose now. And we are sure that this will be used in the future for the patient's treatment. So with this range of Envision Tech solutions we have for depending on the volume and depending upon the jobs which you want to do it, we have the range of solutions from a smaller machine to a higher machine for production, which can really cater to the requirements of the clinics or the labs, dental labs, which is really using these machines for. So in addition to the dental applications, we have ONP, we have medical equipment manufacturing. So all these, we have solutions on this, and these printers are getting used for that. And we are all used to the 3D printing of metal using the laser-based technologies. And laser-based technologies has its strength as well as it has got its limitations. So if you want to really scale up, it is very difficult to scale up the production using a metal machine, mainly because of the heat is getting generated. Basically, the amount of heat is getting generated, the amount of support structures we need to provide on metal machine, and It also limits us to use at least only one layer of printing in one specific print job. So the throughput also will be much more lower. So looking at this, I think the multi-jet fusion technology in metal also, we are able to bring the solutions from desktop metal. We call it the binder jetting technology, which is again targeted for the production of parts, of volume parts. So what it does is basically we have the process called metal injection molding, where you create tools. If basically if the parts are identical, we can always go for a tool and we can create something called a green part. Green part is nothing but a fragile part which basically uses a bonding agent to bond the metal powder, and create a geometry or a shape for it. Once the shape is made, then what we do is basically we will use a furnace really to sinter these parts using a furnace, and the sintered part will be the final finished part for you. So the same process of metal injection molding. Instead of making an injection molding to create the green part, we have this technology called binder jetting technology, which can create these green parts using the 3D printing. And the same green part can be sintered using any furnace of which is getting used for the MIM, or we also provide you the furnace from desktop metal, which can sinter these green parts and give you the metal part finally. So what it does is basically, rather than getting into a laser-based printing, we can put these parts at higher volume by putting it over the stack it vertically and horizontally, like the multi-jet fusion technology of HP. We can create that kind of a throughput from this machine on metal parts. And once the green part is made, always these parts can be put in the furnace to really get it sintered and get you the final part. So this technology is going to be the future of 3D printing in terms of metal, mainly because of it through volume which can produce, or a throughput which it carries, and the cost economy we can bring in 3D printing of metal parts. So if you are looking at these kind of solutions, which is required for you to really create these kind of parts in volume as a service provider, we have a solutions of multi-jet fusion technology for polymer, nylon-based material, as well as basically using the jetting. So if you look at the applications of this, I think whatever applications you are using it for 3D printing, probably if you want to really recreate the geometry of a scanned image and do some test runs, or you have to use it for explaining to the patients, or whatever you want to do with that kind of a prototype, you can able to get it printed. Really strong nylon parts can be done, and you can make it economical by putting across all these concepts of design for manufacturing, scale, reduce the material getting used, and make the printing much more economical. And as I told you, the technologies what we carry is the future of 3D printing, and it is going to drive the production using the 3D printers. So we have the solutions from HP for this kind of production jobs. We have the Envision Tech, which is already used as using the DLP, or digital light processing, basically already getting used in the medical industry. We carry that product also for small volume jobs, as well as we have the binder jetting technology from desktop metal, which can provide you through metal parts at a very high speed, as well as at lower cost. So these are the solutions what we carry, and as I said, you can use these technologies to really drive this technology of digital manufacturing for the future. So I'm accessible over email and telephone. I have listed out both my contact details. If somebody wants to ask, clarify any questions, or if you want to really engage with us, you can write to us or you can call us. We will be happy to help you out. And thank you very much for the opportunity, Dr. Shibu, and I hope we will be able to provide you the technologies the industry needs. Thank you.
Thank you, Mr. Janardhan Venkat, for giving us a beautiful insight into how things are progressing in the industry and how it's actually helping us as clinicians looking at these products. And I think the take-home message was the fact that it's a big number game, and the scale of economics can be completely changed if we can scale up a lot of things, and that's something which is going to be beneficial to all our patients as more and more people start using this technology. I think the cost is going to come down, and we saw the way in which you can actually print about 880 dentures in about 24 hours. I still remember when I was in dental school, we used to use these flasks, and it used to take us, almost 3 hours of curing time, and then trimming, and then it's just a pair of denture, which we would do all day to get it. I still remember doing my grandfather's denture at home as soon as I passed out from dental school. So the scale to which we are now going and the precision with which we can actually do with these printers is mind boggling. And I think it's not too far off when our practices can actually afford these printers. So we can actually do our own printing in our practices. Hopefully, in the future, that itself is going to be a different, disruptive kind of thing. And that's probably for the years to come. That's what is going to happen. So, moving forward, may I invite another distinguished speaker, Dr. Shiva B, who is professor and head of oral medicine at the Best Dental College from Madurai. He's going to talk to us on the kind of technology which is changing in digital dentistry and in the diagnostic process. So, over to Dr. Shiva for his kind presentation.
So I would like to thank Mr. Shibu for giving me this opportunity, and thank you very much, Girish Rao sir, for this introduction. Into digital dentistry, or even for 3D printing, when it comes into the medical line, I think radiology plays a very important role. So this is about 3D imaging, and one thing which we have to understand, another important point is hybrid imaging. Now most of us, where you can use two machines to get the image. One is fusion of two or more imaging modalities to form a new technique. So why is hybrid imaging important in 3D printing? I think most of the times neurologists, they want to print a tumor. They want to see where is it located within brain. We have an option, either you use a CT or an MRI. But here MRI gives you a better imaging of the soft tissue, and CT a better imaging of hard tissue. Why don't we combine both? So in hybrid imaging, you have PET CT, which is a medical invention of the year in 2000, which has come out in the magazine. It's a groundbreaking technology because here you can see tumors as well as its location and fused both the images together. So this is a small picture of PET CT, which I'm showing you. You have both the machines together. One is you have the PET, and the other side you have the CT together. So you have existing hybrid imaging modalities. One is PET CT, SPECT CT, MRI PET, MRI SPECT, ultrasound and MRI, ultrasound and CT, MRI and CT. So in fusion, people do have a confusion here. In software approach, you have images are acquired on separate devices, imported into image processing workstations and registered, and fused using dedicated softwares. Hardware is what I showed you all. That is the hybrid imaging. I'm sure many of you all have used softwares where you can do fusion, taking images from two, CT and MRI, and fusing them together when you want to see a tumor or the location of a tumor. Now, pathology of interest dictates which technique you use. In 3D printing, suppose a neurologist wants to print a tumor location, then it's fine to go with MRI and CT by using a hybrid technique of fusing the images. When you want only bone, CBCT is the best. As you all know, the spatial resolution is very good. When you want only soft tissue, go ahead only with MRI. So the latest, I would say, fusion is power, because here most of us are dealing with tumors and 3D printing of tumors to see their location, or in guided surgeries, how to go about doing the surgery, and how is the entry point, and how much is the size of a tumor. Now, most of the time in CT, you don't get to see the borders of a tumor very clearly. But in MRI, yes, soft tissue is very clear. So you get to see the boundaries of a tumor very clear. So I told you all about fusion. And in 3D printing, we have to decide on what pathology which is which is of interest for us. As I said, fusion is power. And this is, you can just see the image here. I've taken it from a journal article. You're using a CT machine and an ultrasound and fusing both images for a guided surgery. Of course, with ultrasound and CT, you can't 3D print it, but it's just an example for showing you how to fuse an image. I'm sure many of you would have seen this article, Hybrid Imaging 3D Model of a Human Heart by Cardiac Imaging Technique, CT and echocardiography. So I used a hybrid mode here. You're using echocardiography and CT to see to 3D print the heart. Here a small example, of course, oral surgeons and maxillofacial radiology. We have used the MRI and CBCT registration, which provides a reliable tool to reconstruct 3D models of the TMJ soft and hard tissue. You can see the bone, which is seen in almost orange color, and then MRI behind, which is fused together to show you the location exactly. Now this is hybrid computer tomography and magnetic resonance imaging. You see a tumor here and a brain stem here. So you know the exact location of the chondroma to the brain stem. When you 3D print it, you know how to go and how to access it. So these are the small images that have been done. One is with the CT and then with the MRI. You're fusing both of them to get a 3D printed model. Another example is the ultra-fast cone beam CT imaging and post-processing data during image-guided therapeutic practice. So what has been done here is ultra-fast cone beam CT you have taken, a cross-sectional image. You have perfusion blood volume, which is here, and then superimposed, or you get it as fusion. So you have CBCT MRI fused data used to delineate and differentiate the treated tumor. Ahead than this, you also have images in 3-dimensional where anatomy, metabolism, functionality, and even the elasticity of an organ are perfectly superimposed. So you've gone into total fusion mode. Here is another example. You've taken a CT image. It's a tumor here. You remove that tumor, you segmented one part. Then you've taken an MRI, you segmented another part and fused both and done a 3D printed model. So it's multi-mode image acquisition for 3-dimensional 3D printing. Now 3D printing applications for radiology, when it comes to what are the most important points which are required here. One is, we all know you're going to do the image acquisition, then you're going to do the segmentation part, the image post-processing and validation. Validation and model accuracy is very important. So I would be speaking on the image modality process, gaining of data, the facts which are very important, and critical steps between data and model. So let's go into the image acquisition part, the critical steps between data and model here. Now this is just an example here. You have a 1.5 Tesla and a 3 Tesla MRI of the brain. You have two images that can be seen. You see now I'm pointing out on a pointer. You can see here. And the left side, you have the right side and the left side. Which of the images are clear here? To me, I find it the left side is much clearer. Let's see here. Image acquisition is evolving along with image registration. So the registration algorithms which we usually do, it is driven by intensity information, find it hard to differentiate between image differences caused by biological process and those caused by details of image acquisition. So the registration algorithm itself finds it difficult to differentiate between the image or certain artifacts caused by the machine and certain images which are caused by the biological process itself. So we should carefully deal with when you want to demarcate structures completely for 3D printing or getting out the model. So one important point here is we all need a very good spatial resolution to clearly demarcate the structure which we want to 3D print. We all know that CBCT gives us a very good spatial resolution between soft and hard tissue. That is it. Now, here is an image of a CT. You have bone window, one on the to my right and one to my left. The left one is blurred, but you see the right one is very clear. It has a very good spatial resolution. You can demarcate the outline of the bone very clearly. So this is very one important point. Next important point is the slice thickness. Remember when you send your patient to a radiologist and you tell them, I want to print a 3D model of it. I need a very good scan with good clarity. The slice thickness influences the spatial resolution and the noise. So spatial resolution, I showed you an example of the image. You should differentiate between bone and soft tissue clearly. But then you also have image noise here. So the anatomy of interest, if it measures 3 mm, make it sure you will get 3 slices of that particular anatomy of interest. Only then, when you prepare an STL file, you will get it very clearly. Otherwise, you would have step type deformities there. Coming to slice interval, you have continuous intervals, non-contiguous intervals, and overlapped intervals. So a small picture here. You can see the slice interval here. There is no interval in between, but here in 2 slices, you are creating an interval in between. You're making it like, overlapping. You're overlapping your slices. Fine. But here, non-contiguous, you have left a gap in between. Do you think you would get a proper image with leaving a gap in between the slices? You would not. So always prefer to take a continuous slice. Voxels, a very interesting topic when it comes to dental imaging, because CBCT voxels are isotropic. Whatever measurements we do on a patient is the same measurements that we can do on the computer screen on the DICOM file. But is it the same with CT and MRI? I really doubt. I always have a question I keep asking people, does MRI and CT give you all isotropic voxels, or are they anisotropic? So how are the measurements after you print a 3D printer model? Does it really match the exact size of a tumor or the exact size of a skull of that patient? So that is a question here. So this is just an example of isotropic and anisotropic. You know the voxel size is different. Coming to signal to noise ratio and contrast to noise ratio. You need a very good signal compared to the noise ratio so that you have a very good image. So a higher signal to noise ratio, all else being equal, implies more trustworthy data for 3D printing. So if you don't have a good signal, there is no use in taking that image to demarcate a tumor and give it for 3D printing or any structure which is going to further go into conversion to a STL file. So high contrast between various organs in the body is an important feature of medical imaging and is necessary to delineate structures for 3D printing. So high contrast. So can we demarcate a tumor looking at an MRI exactly, that this is the boundary exactly? No. I feel it is time that you all involve PET imaging or fusion imaging when it comes to exactly demarcating the size of a tumor. But an open thought that I do not know if there are softwares which can be used on PET CT where you can segment only the area which is highlighted by a PET image. Next example, you can see here signal to noise ratio. You see a very clear image here, but look at this image. More of noise. There is no signal here. There's more of noise. The second one, you have contrast to noise ratio. You can see here, you can see structures in between here within this square. Okay. But look at this. You don't have a contrast. You have more of noise here. Dots, too many dots. But here you can see structures clear. So we also use image filters. I don't know if many of us have sent our images to radiologists to take up the scan, but we do not know what are the filters they have used. One, you have to know that you have to use a sharp filter when you want to demarcate an area properly. So you have filters from sharp to smooth. Sharpening filters increase the edge sharpness at a cost of increasing noise. But while smoothing, filters reduce the noise content in an image by also decreasing the edge sharpness. So it's wise to use sharpness filter rather than using a smooth filter, so that you can demarcate an area, demarcate a tumor exactly. So image artifacts, we know CBCT causes image artifacts of implants. There's streaking artifacts. But in 3D printing, can be limited by the presence of artifacts, motion, or other spatial or noise limitation in DICOM images. So when it comes to image artifacts, how do you reduce the artifacts? The region of interest should be small enough to enable confident segmentation for 3D printing. Of course, here we take up a full volume scan, a huge scan. So if you can avoid the area where there's implants or any metal processes placed, you can have a 3D scan of a patient without any artifacts. So image data preparation and manipulation of the image segmentation. So image data preparation, you have DICOM images, which I say is uncompressed DICOM files. So let us understand, as surgeons and radiologists or medical professionals, once a scan is taken, your data is already compressed automatically by the computer. It is automatically compressed, but we don't understand that when taking a data, you can also suggest your radiologist to take it with a high definition scan, and you can tell him that I want to 3D print this model. We are going to use it for a planned surgery. So operator should be aware of any reduction, smoothing, or further file manipulation or optimization within the segmented software. So you are doing smoothing by adjusting the images. You're doing some reduction in the sense, I would tell you, when you can even take a high definition scan and change it to low definition. That is, there is a term called interpolation. You're adding up voxels together to bring it more smooth. But the fact is, the sharpness is reducing. So once you do the image segmentation, you get a STL file. You all know STL files are triangular faces. That is, the number of faces can affect anatomical accuracy of the model. They're just triangles. So typical segmentation software packages allow for final STL to be re-imported and its contours displayed over the original DICOM file. So this point is very important here. If you can take a DICOM image, convert it to STL, bring in the STL file, overlap it with the DICOM image again, and see if it is exactly of the same size, shape, involving the entire tumor, then it is accurate. So just a small picture showing you the triangular faces, that is of the STL file. So what are the mistakes you can do in segmentation? A common cause of error. So you know the definition of a surface which requires that any surface must be enclosed space. For this reason, open regions of interest cannot be rendered in the STL format, and users must manually edit the STL file using CAD design softwares. So you have to be good in the designing part. Again, these are the challenges you face. I've told you all, beam hardening, air, metal, implants can cause artifacts. So according to the Radiological Society of North America, 3D printing special interest group, physicians carefully document alteration made during post-processing. So please ask your radiologist what post-processing techniques he has done before supplying the images to you. Has he increased the size? That is, interpolated the voxels and then given it to you so that the image looks very good, but there is less sharpness for you to demarcate a tumor. So it is the surgeons or the one who is working on the image, it's his duty to ask the radiologist. So let's coming to the validation and most model accuracy. You have printed a 3D model. You can take a scan of the model, overlap it with the scan which you have already taken, and see if it is of the same shape, the same size, and the locations are the same. So you can validate a model, which is most important, very important when it comes to tumor planned surgeries or planned surgeries. So as we all know, head and neck region, neurologist, you're involving a neurologist. You have neurosurgeons, ENT, cancer, oral surgeons. Just a classification by the international, that is the 10th revision, the classification of diseases. And the most important point, craniomaxillofacial surgery has both a functional component and an aesthetic component. So here we have to be very careful, as Girish Rao sir had presented a very nice thing about surgeries that he has done. You have here a functional component and an aesthetic component also. So when it comes to functional component, it is the oral surgeon and the maxillofacial radiologist who have to involve and design an implant, not give it to an engineer to design it, because you have a functional component. You and I know how a TMJ functions, or how is the rotation of the condyle present, what is the shape of the face, or is it a, he has an, what is his occlusion and everything. So we all know computer aided designing, computer aided manufacturing CAM, but let us also understand CAD assisted medical training, where you have to train, you could train with a 3D printed model before you could go in for surgery. That is in case you're doing a complicated surgery. It is one of the emerging technologies. And finally, I have to say that we all have to work together, because if it's surgeons, radiologists, and engineers, of course, here we have biomaterials. We have to understand the biomechanics of a jaw movement or the facial structure. You have to bio-design an implant exactly to that particular patient. So the world of computer-aided design and simulation is evolving to a more realistic model, which has industries beyond engineering taking advantage of its capabilities. So one is 3D printing, and of course, we also have to understand 3D simulations here. So these are just study models. I think most of you all in the 3D printing line would have known very well. A CAD skill here. You have 3D printed an implant exactly to fit for the upper and lower jaw. Here, as I said, biomechanics. We would also have to know whether this implant can bear the stress of the jaw movement. The patient is going to chew food and bite his teeth or his processes. Compatible material, biomaterial, and it's a bio design, exactly designed to suit the forces here. A small example of a tumor being 3D printed after taken with MRI. You can see different colors given here for our understanding. A very important point, CAD assisted training. I had gone through a site. This is a company called Facon GmbH from Germany. If you're going to plan for a surgery, you take a CBCT or a CT MRI image, you put the file in a computer, they prepare a CAD model, 3D print the model with a material similar to that of skin and tissue, and link it with the CBD CT scan or the MRI scan in a computer. As you do the procedure, a trial procedure on the 3D printed model, you can virtually see it happening on the computer screen. So any mistake you do here will beep on the computer. It's a CAD assisted training model. I think surgeons should surely look at this site, Facon GmbH. You have models for ENT, for neuro, and for other areas also. One more important field, I hope, as a oral medicine person, in the field of oral oncology, there is 3D printing of the VSP bolus solutions delivers high quality patient specific device that contour to the patient's anatomy, enabling more efficacious treatment and a more comfortable experience. In radiotherapy, you're blocking this area completely and preventing it from radiation using a 3D printing method. It's nice to know this. The second, you are immobilizing a patient in radiotherapy, the bed or the table before you can go in for radiotherapy, because the patient shouldn't move. So you prepared a 3D printed model, processes to cover the patient exactly so that he doesn't shake. And of course, we all know that it's a very valuable avenue that 3D printing has come up. It's a very good technology. We would also be involving simulations here and CAD assisted training. So technologies such as 3D printing could be great allies for radiologists in redesigning their roles. And of course, a few days back, a liver was completely 3D printed with a bioprinter by 3D Systems. And thank you very much. If you'll have any doubts regarding the imaging part, you can always approach. I'm ready to help you. Thank you.
Thank you, Dr. Shiva, for that fantastic presentation. And I think it's absolutely important for clinicians to basically, specify what is that you want to the radiologists. You see, one of the things which a lot of times happens is you would have sent the patient for a CT,
Yes,
and
sir.
then basically you think, oh my God, I wish I'd actually asked for the details, basically, getting finer sections, not to compress the files, and
Yes, sir.
having higher resolutions. These
Yes,
are
sir.
very, very important because I think as more and more people start using it, you start seeing these kind of simple problems which you come on to your day-to-day practice. So I think you beautifully elicited the kind of things from a radiologist's perspective, beautiful, and especially the fusion, the
Yes,
things
sir.
which are
Surely.
happening. I mean, I still remember the first presentation where This was way back in, I'm talking about in 97. British Telecom, believe it or not, they came to the BMS, that's the British Association of Oral and Maxillofacial Surgery, and they talked about technology, which is going to be a game changer at that point of time. And we were all registrars and senior registrars at that point of time. And we looked at how they were able to bring in a CT image, a MRI, and then an MRA. They were bringing in how the vasculature around the tumor could be beautifully defined. And we were all stuck with the awe to see the kind of fusion which was happening. And it's nice that you are also showing these kind of things now. And it's nice that this is available today.
Yes, sir.
When I in the Oncology Institute at Bangalore, the Sri Shankara Cancer Hospital, where I practice, today we see a lot of these kind of things. Almost every patient gets these kind of images done. And in the tumor board, when we discuss, we have better outcomes because of the fact that we are getting better definition of the problem and how you can come up with solutions. And that's where,
Yes,
when
sir.
we bring specialities together, it's really, really beneficial to everyone.
Yes, sir.
Thanks for the wonderful presentation.
Thank you, sir.
It was very good, and continue doing this beautiful presentation. May I
Thank you,
call
sir.
upon the next speaker, and who is going to be the last speaker for this session, Dr. Pranav Sankalp, who is one of the co-founders of Lucid Technologies in Lucid Implants from Nagpur. Dr. Pranav, the stage is all yours.
Good afternoon, one and all. Greetings from Nagpur. So, I am the director at Lucid Implants, which is in the center of India, that is Nagpur. Nagpur is also the tiger capital of India, and it's famous for oranges. It's also the geographical center of India. So, moving on, as my topic is 3D technology, a game changer for dental and medical. Uh, as the topic suggests, whether it is really a game changer is, according to the commercial point of view, yes, it is, because previously when we talk about very big companies like Johnson & Johnson, Deep Eye Synthesis, KLS Martin, the investments that these people have done to make the implants were very huge at like 10 years back. But now, because of these things, even small and medium class companies are also entering into the medical field, and this happened only because of 3D printing technology. So the budget or the requirement of the funds that is required for a patient specific implants, though it is for any part of the body, mainly CMF and orthopedic implants, is now possible. And because of that, you will see that there are maximum people in India who are going for company formations, and because of this only, there is a reduction in the import of these implants from Western countries, and because of which the overall cost of the implants is also going down. So this is what I see. Whether it is really a game changer, yes, it is from the commercial point of view.
Please go ahead.
So we are into these patient specific implants, which are mainly made out of PEEK and titanium. uh, PEEK is a polymer. It's a polyether ether ketone polymer, very complex polymer, which melts at 500 degrees Celsius. And when you print PEEK instead of titanium, like, which melts at around 1600 degrees Celsius, so the laser that is inside the metal printer goes up to 1600 degrees Celsius, and it fuses to molecules or the atoms of these titanium particles. However, it's an alloy, Ti6 aluminum for vanadium. So these are two materials. As far as the third materials, which is also used for the craniomaxillofacial reconstruction, is ultra high molecular weight polyethylene. That material is used because it has huge tribological properties. Tribological properties, nothing but it doesn't wears out easily. So moving on, these are cranial plate implants, which are for non-load bearing implants. Non-load bearing means the load is only around 5 newtons to 10 newtons, which is like 0.5 kg to 1 kg. Again, going on to the mid-face implants, you have subperiosteal implants, orbital floor zygomatic implants, and load-bearing implants. Like suppose in case of mandible implants, you have hemimandible implants, segmental implants also. Uh, Then you have reconstruction with for TMJ implants, where the mandible component is made from titanium because it has to bear the load. Generally, a masticatory load of around 500 newtons, which is around 45 to 50 kgs, comes with a full bite. So when you are cracking a nut, then this much amount of force is coming. That all force will be transferred from this titanium joint to the fossa component, and again it is a fatigue kind of a loading in which continuous wear is going to go. So whenever we talk about orthopedic implants, there is a what we call as in engineering term as the fatigue load. It means that a repeated load for a minimum of 1 million cycle, that is 1 million gauge cycle, it has to sustain. So in my presentation, I'll be talking about the design of the implant and its verification from the finite element methods. And let us see that because generally the design that we do is generally for, suppose, maxillofacial implant, someone will say that okay, the plate thickness that you can take is around 2 mm. Someone will say no, I can reduce it more to 1.5 mm, but I can make it like 1 mm and 0.5 mm also. So it's the printer ability to print it, but whether that thickness will be able to support the load or the implant would fail otherwise. So what is the exact thickness that we can have in nasal portion, also in the zygomatic buttress portion, has to be defended with a logical argument. I think a finite element method is a very good thing to support that argument. So then we have overlay implants. Again, this is non-load bearing area implants like mandible angle implants and chin implants. This is basically for the aesthetic region. So I am changing the slide. So I'll just explain the process of PSI. The first, as before the speaker he said about taking the DICOM files, and so it starts with there that you take the DICOM file, CT scan in DICOM format. Then you have the segmentation of that thing, and as our company is accelerated by Dassault system, we do everything in Dassault platform. Then you have the anatomical model printing. With the anatomical model, the doctor and the patient can sit together. He can explain that this is the problem and the patient can understand it. Then you have the printing of that thing, and then you have the post-processing and packaging. In our company, when we receive the DICOM, we receive the DICOM through a HIPAA compliant system. This also system is provided as by Dassault systems, in which you can upload your own CT data and will be will be saved into the platform and will be available for lifetime. So nobody can hack in the system. That is why it is HIPAA compliant. With the present thing, we have provided implants to around 23 states in India, out of which major implant we have given to Chhattisgarh, Maharashtra, Kerala, Delhi, and Karnataka. So now moving on to the cases, we'll see what was the problem and what was the exact design and whether the FEM supports that design. So this is how we'll proceed with this thing, and I'll be also telling you about the FEM thing, which is rather very important, not only for students for paper presentation, but for validating the argument and to convince the doctor that yes, the design is correct, because these are what the results that we have. So now let's move on to the first case, like the peak implant case. Now, in this case, if we say about the cranial implants, whenever we are sleeping, around 5 kg of load is coming. That is the weight of the head. But if suppose someone hits you with a tennis ball, then around 130 newtons, that is 13 kgs of force in impact, is going onto your skull bone. So what should be the design? We'll talk on that. However, in this case, this was the defect. We can reconstructed it. It was a 59-year-old patient from Nigeria, Africa. Chief complaint of anesthetic depression on skull. Defect poses a risk of direct injury to brain if left uncovered. So this was the treatment plan. Was we designed the peak plate, and the thickness that we kept for the peak will be definitely more. Why it is more? Because titanium is much stronger than that of peak. In terms of, let's talk about the yield strength. Yield strength is nothing but the strength of the titanium. So if you go beyond that, it will break, but if you are within that limit, it will not break. So for peak, it is only 88, but for titanium, it is around 1110. So 1110 megapascal of stress it can sustain, but peak can only sustain 88 megapascal. So this is the surgical photo. However, in this case also, it has to be fixed with the help of titanium plates. This was a second case, and a very big size case was operated by Arun Oman at Lakeshore Hospital. 75% of the bone was gone because of mucormycosis. The patient was only 30-year-old. Again, in this case, we have not selected peak because the load that is coming, that is 5 kg, is onto a specific area. But in this case, as 75% of bone was absent, the stress at a point which will come will be so huge that peak might crack in that region. So that is why in this case we have decided to use titanium, and the thickness that we took for this case was 1.2 mm. Now, this was the case in which we started doing FEM and started deciding what is the thickness which is perfect for cranial, because the minimum it is better. So in this, there was a defect on left side and right side, and yeah, as you can see here, then we designed the implant. This is how it was fixed, and let us see now on the simulation results. So now when we do any simulation, we this is nothing but a kind of a Carnot cycle, which is the ideal cycle, and then we compare our results with the FEM results, and then we justify. So like in case of rest state, when you are sleeping, it's around 50 newtons, and the force which will be coming onto the cranial plate is perpendicular to the surface, and that is restrained by the clips that you have. So now one important thing that I would like to tell everyone, that in this case there are two kind of bone. One is the cortical bone and second is your implant. Now let's see the yield strength property. If you can see 1116, it's so huge, whereas cortical bone is 122. However, the bone has to be replaced with a material which has the same properties that of bone, so that the brain or the osteoblast cell line or osteoclast gets confused that is there any real foreign body or not. So the property of the implant should match with the property of the host tissue, is what in tissue engineering lectures we have heard by different people. Now in this case, we applied a load of 50 Newton and also 135 Newton, that is impact of tennis ball hitting. Now these are the stresses which are coming. In this case, maximum displacement means when this much force is applied, this much plate will bend. However, it is very, very less. It is 0.06. That is why we don't see it with our visual eye. And the stress which is coming is 74 megapascal. Again, for when the tennis ball is hitting, it is 0.09, more than 0.06, but the stress is 101. Now this stress has to be compared with this stress, which is 1116. As this value is less than that yield strength value of the material, the plate is safe. Let us see the simulation. Can you see my slide 24 as of now?
Yes,
Hello.
yes.
You can see, right? So, and you can also see the video, right?
We can't see a video.
Acha, let it be. So, acha, theek hai.
Now,
Let us play the video.
we could actually play it. Let's say.
So now you can see, right?
Yes.
Okay. So now you just imagine that the person is sleeping at the rest state, and how the stresses are being transferred onto the plates where it is fixed. That is one thing, and the important thing that I wanted to show, that now in this case the design can be changed, that really do we need 6 screws for this, or can we reduce the cost and the material by introducing just 3 screws? Because in the simulation we can see that there is no stress which is coming on the this bottom screw where we have fixed it. So why we should invest our money and put more screws and make things more complicated? So there, that is not at all required. Now let us see the second this thing for displacement, means how much it is going to bend when you design this at a cranial plate which is having a thickness of 1.2 mm. It is bending to 0.09, and these are the stresses which are coming onto the plate. So not much. 0.09 is 90 micron, is nothing. So then we thought that okay, we can proceed with this thing, and we gave the cranial plate to the surgeon. Again, this was a frontal bone defect. Here also it is non-load bearing. Anyways, here it peak is much more applicable. Thickness can be varied from 3 mm to 3.5 mm, and this is perfect in this case. So we went directly for the frontal bone defect reconstruction with the help of PEEK implant. Anesthetic depression and chronic pain on the forehead region was observed. History of low road traffic accident. It was a trauma case prior to the admission. Compromised his appearance, social life, and self-confidence. Again, that was done by PEEK reconstruction. Coming on to the orbital floor cases, titanium mesh is used by maximum surgeons, but in this case it got infected and there was discrepancy in the volume of the globe. So we took out the titanium plate and we designed the customized PEEK implant. Again, if you see, however, in this case FEM was not required, but still we thought that what is the load which is coming onto, or how much load a eyeball gives onto the orbital floor. So it's around 10 newtons. So when you are skipping, that is exercising, what happens, there is a continuous impact load which varies for about 5 newton to 10 newton, means 0.5 kg to 1 kg it goes. So orbital floor PEEK we have taken the material, and cortical bone we have taken the material, and we have fixed the implant, because in the surgery we'll be fixing such implant on the zygomatic and the maxillary bone. So let us see what are the results that we have. These were the simulation results, and if we see that we all understand, if something is fixed at one point, there will be a bending on the other point. In the simulation you can see how it is having the red region, which is having a displacement of 0.04, that is only 40 micron, is very very less, and how the stresses, now in case of load bearing, these stresses are continuous, every time it is going on. And then again we decided that okay, we'll take this thickness, and the surgery was done. Similarly, for zygomatic reconstruction, such kind of implants were used, and PEEK was very well suited in that region. However, for if we move down to load bearing, some of the surgeons, like this was done by Dr. Atreya Rajgopal, and this was an edentulous case. Some people told me that in this case, Pranav, PSI is not required, we can do it by implants, but this is like what the doctor says. Now this was a fixed abutment kind of arrangement in which cement reinforced crown can be placed. That's it. In this was a 42-year-old patient with atrophic maxilla and mandible, poor appearance and reduced function of existing complete maxillary and mandibular dentures. So the PSI was designed in this case. However, because of the infection or because of the flaw in this design, screw retained design was used. So what we did is that we did all the scanning of the implants that are standard available. So as you know, there are two segments. One is Israel company and second is the South Korea. South Korea is like Ostium and all. Here you have Norris, Genesis, Zimmer, and Adin. So we scanned those implants, and what we did is that we introduced that threading into the PSI, and then we started fixing the standard implants there. So this was a screw retained abutment in which a screw retained denture can be placed. Now, if we talk about this design, it's very important in this design, because if we see the FEM analysis, you'll see that anterior in the abutments first, which are in anterior, it's about 135 newtons. Second, it's around 300 newton. Third abutment, we have taken a force of 400 newton. So 13.5 kg, 30 kg, and 40 kg at a time on the implant is being applied. And these are the stresses that is coming. So a lot of stresses are coming, and if you see just the video, you'll find that the most posterior, the displacement is 1.37 mm. So it's like when he's biting, it will bend to 1.37 mm. So now again the discussion can be whether that location is correct, whether it should be all on 6 or it should be all on 4, is this thing, because this much if it is bending, 3D printed titanium implants are not ductile at all or malleable. They cannot bend. They cannot be driven into sheets. They are like glass. So that is why the Poisson's ratio of a 3D printed titanium is 0.33, whereas your normal titanium, which is made by using casting, is 0.3 only. So more the Poisson's ratio, more it is brittle. So that is why you cannot bend these implants, and this implant would fail. So this we found out in case of FEM study. Again, this was done by Dr. Rudgi, and he wanted a screw retain kind of arrangement. So in this case, again the implant was given, and screw retain denture was placed in this case. Coming on to the complete hemimandible kind of cases, this was done by Amish Chaudhary at Faridabad. Uh, the resection guide was provided. And now, two are different views in the doctor. Some say that okay, we will put the implant into the natural fossa. However, some says that we need a ultra high molecular weight fossa also. So depending on their requirement, we have to proceed like. So this was the planning. This was the ameloblastoma, and the guide was given, and it was resected, and then the PSI was placed in this case. Now, this was a perfect case. In this case, if you see the FEM simulation of this thing, in premolars, this much load was applied. Again, titanium cortical bone as two materials were taken. If you see the stress distribution, you'll find that when I load it, you will see how the stresses are coming onto the titanium plate and they are transferring to the bone. So the red region here, it is going as 1.2 into 10 power 8, that is 120 megapascal of stress which is coming. Definitely the titanium is not going to fail, but still whether that much extension of the plate was required is a question. So these are surgical photos. The guide was placed, it was resected, and it was resected and the surgery was done. This was done by Dr. Abhay. Maximum mucor cases are there nowadays. So again, two-piece arrangement because lot of incision area is not available. And in this case, now as there is a GDC project is going on with Lucid, we are providing the implants and they are just going for temporary dentures as of now. So this is that case. This was a case of Dr. Sai Santosh from Andhra Pradesh. Again, 60% of the maxilla was gone. In this case, 4 abutments the surgeon asked. They discussed with prosthodontist and then they decide on that. Again, the surgery was done and that went fine. In case of mandible, this thing, however, in this case, we have provided a fossa. 2 screw retained abutments were provided in this case. These are the surgical photos like that. So let us see in case of fixed abutment mandible, what are the forces and how that is transferred to the fossa. In this case, in the second design, you will see that we have not given that much extension. However, in the first mandible case, I have given extension to the other side till the ramus, but in this case I have not been because it was not required, the stress was not coming. So in this case we stated that okay, let us give the load of 200 Newton and the load of 300 Newton in the second abutment. You can see the results here that the so much red portion you have. So the displacement is 3.35 mm, it is coming. Plastic strain is 0.23, and if we see the video of this, you'll find out how and how it is moving. So let us see this. So we have fixed it at the 2 fossa regions, and when we apply the force, this is how this much the at the neck you will see that the one, my sister. So these are the regions where your implant will be failing, and in this region where the implant is failing, more material needs to be added so that that region becomes stable, and the region in which there is no stress which is coming, you can reduce the thickness at that region. Coming on to some of the plastic surgery cases, peak is well suited for non-load bearing areas. So for mandible correction, also you can edit peak material during the surgery. You can trim it with the normal bone cutters like that, and you can fix it with just titanium screws. So you can see in this case that we have the surgery was done. One more mandible overlay surgery was done by Dr. Sonal Achalia. This was, you can see that there is a depression on the left side, and again the peak implant was given. The surgery was very good. It has been around 1.5 years we have done this surgery at Ahmedabad GDC. TNJ joint reconstruction, you can see one of the cases that we have done pre-op and post-op. This was the surgical planning. The mandible, the sir said that bring the mandible down, tilt it in front. It was Leaford kind of surgery, and then the fossa was designed, the mandible component was designed. In this this is the 3D, but the video is not running as of now. So these are the surgical photos. One case we did with Dr. Anand sir, in which we used all the three materials. Mandible component was done by titanium. This was done by ultra high, and there was a locking mechanism between the maxillary peak overlay implant and the fossa component. So this was a wonderful case. We did around 11 to 12 iterations. This was my first case with the surgeon. One case which one of the actors, Sonu Sood, has sponsored was which was operated in Amrita Hospital, was a very intricate case. So there we designed this peak implant and the fossa was given. Now coming on to I'll be just finishing my presentation now. What we thought as our second program that we thought is that whenever a case is uploaded, there is a lot of time which is invested in the planning, and the second time which is wasted is in the communication. So we thought that we will start with a lucid astral program. In this lucid astral program, we install printers and we put our guy into the with the surgeon, so that maximum amount of planning and the 3D printing courier and everything is reduced, and the final implant can be given directly by the company. So we have moved forward with this concept. With this kind of astral technology, you have mandible models, skull models, resection guides you can make, drill guides and dental models you can make in your own lab. So we have signed this agreement with HCG in Nagpur. They are using our facility, and one more at different location. The doctors who are very very early adopters, kind of a thing, we are giving this facility to them. And this is like lucid astral facility at Varanasi. Now we have entered into the orthopedic section, where the orthopedic implants are required. So this is Dr. Amit Jaiswal, and we provide him with the pin positional guide for the knee replacement implants. So this is from my side. Thank you very much. Yeah. So I am done actually.
Thanks, Pranay, for doing a very nice presentation and showcasing different of our maxillofacial surgeons across the country who have been doing some wonderful jobs. Cutting across the country, I think we have been very early adapters in using this technology. As the secretary of the association, as I told you earlier, we have a huge responsibility. And I think, 3D printed technology is going to be definitely a game changer for these mucormycosis cases, maybe even in a lot of cases like benign tumors, where we can probably use this in a very big way. I'm not sure still in malignant tumors how we are going to use this patient-specific 3D printed prosthesis. One of the biggest concerns what we have there is the radiation which is going to be used, and many a times when we have a multimodality kind of treatment where we have even using chemotherapy, where there is a very high risk of infection. And that's where I think when we start working with different academic institutions. I mean, yesterday I was in a panel of both hard tissue and soft tissue kind of cutting edge technology which is happening there. We were discussing as to how we can use these antibody implanted kind of materials, like which are antimicrobial more than anything, which can help in chances of infection becoming lesser and lesser. And that's probably one of the biggest concerns where we have. In fact, I had one case where things went on very well for the first couple of years, and then suddenly there was a breach in the oral mucosa, especially when you're putting in dental implants, right? As long as the tissues are completely covered, there is not a major issue. But once we have a communication coming in from the oral cavity, if patient's hygiene is not very good, or for whatever wrong reasons you might say, the implant can get infected, and it may end up with removal of these implants. So I think it's absolutely important that we have a proper case selection, And we try to bring home to the message to the patient that you need to be extremely careful. You need to come for regular follow-ups, and we need to be very, very cautious in the way in which we deal with using a new technology. And I'm glad we are recording a lot of these cases, and over time we can see how well this new technology is being adapted by all of us as professionals in our day-to-day practice. I think it was a fantastic line of lectures, starting in the morning itself on a Sunday. We've had almost more than about 3.5 hours of deliberations. And I think it's absolutely important that we all, probably start working together. We form a core committee kind of thing, especially when we are talking about practitioners who are using this on a day-to-day basis, bringing out the problems which are going to be there. And we work with the industry and also, academicians, so that we modify things as we go along. I think one of the key things is course correction when you have a problem, so that this technology can be very well utilized by all of us. I would like to again thank Shibu for involving AMSI in a very big way. And it's been a great opportunity for me to come in and understand a lot of things which are happening in this field, especially when I listen to people from IIT and ISP and the industry, as a matter of fact, to basically, otherwise, as clinicians, we are only looking at it. The elephant in the room is only seen from one angle. But when we start looking at it from a holistic approach, all of us can pitch in, and probably that is where forums like this can be hugely beneficial. And I'm looking forward for organizing more and more of these kind of meetings through AMSI, so that a lot of clinicians can get the benefit out of it. Thank you so much for inviting me for this wonderful seminar, virtual seminar. And I do hope we can actually meet in person and, discuss on a face-to-face basis in the future. Thank you.
Thank you so much, sir. With a dignitary of speakers and experts who have really shared some great insights of the subject. And also, sir, with your presentation to begin with, I think we could not have expected anything more in terms of for a great start. For also having been involved in this technology for almost 20 plus years, you've been actually actively practicing and using this technology. Though now that we see that there is a lot of proliferation happening in the technology, and I'm sure, sir, with time and working in conference together, as you mentioned about the session yesterday, there's so much of eye-opening, remarks and solutions which has been discussed and shared by these experts, maybe in closed doors. But now I think the interest is also to see that, for us to work together to see how it can be commercialized. But yes, they are also waiting for the human trials. So there are steps that we need to take as we progress. And also for government's initiative, also now that we know that there is also a national strategy for additive manufacturing. So I think the pathway is set. So I think that will all be implementation process for us to take things forward, sir. So so I would rather want to leave it to you to also discuss with all the other panel members for a short 30 minutes, if we have that liberty to then get some points and then have a conclusion also subsequently, sir. Do you think another half an hour to discuss, and then you can close it, sir, as per your choice, whatever your convenience. So these inputs can be of great help. I know content-wise, everybody has shared some great value content, but with some inputs coming from each of these respondents, with experts already on our panel. So I thought let us take the best out of it.
Sure. I'll open the floor for discussion. I think if John Neeson is there, if you would like to give a couple of comments, John.
Yeah. So I think Dr. John is missed out. I'll just remind him and call him if you don't mind, sir.
Okay.
For
That's not
seconds.
a problem.
In the meantime, somebody else
call upon Dr. Dinesh Jain. We'll go in the order itself so that we basically have everybody's input into it.
Hello. Yes, I think am I audible?
Yeah, Dinesh, very much loud
Okay,
and clear.
I'm really, really very happy to see that Shibu has been able to bring so many aspects together, and not only for the dental but for all the other fields as well. Now, coming back to the points of discussion, I think so much of things are happening that more and more this kind of sessions would really help us improve our knowledge as well as benefit to the end users who are supposed to be the people who will eventually be contributing to the vast expansion of the technology which is going to happen. Somebody will have to invest, so it will be the corporates. Also, that benefits will have to eventually be passed on to the end users in ways of better facilities as well as maybe better quality of life that we can impart, which is our responsibility as such. I think those are my 2 bits. Otherwise, of course, the subject is vast. We can really go on talking and continue as much as. So maybe any other panelists that you would like to summarize certain things. Thanks for giving me the opportunity once again, and thanks a lot, Girish, for conducting the whole program in a fantastic way. I must compliment you for this. Thanks a lot.
Thank you. Thanks, Dinesh. Mr. Janardhan Venkat, if you have any comments from the industry perspective.
Yeah, thanks, Dr. Girish. I think we as a company are into this for the last 10 years. We had seen the growth which is happening. So okay, as a company, I think we always, as a sales guy also, we always prefer to get into a field where it is a little more matured in terms of, so our focus was mainly on the automotive, and we had seen a lot of progress in that area. But I think of late we have the technology right now, which is going to help the medical industry, and we are refocusing on that right now. We had some solutions earlier on medical, which we have started a few years back, but because of lack of actual solutions, what we had, we just taken a vertical back foot, and then now we are just getting into that because. But the objective, say, if you look at as a company, HP, when they launched the MJF, and when we discussed about our strategy, go-to-market strategy, what we found was that this is an industry where we need to have organized players like the labs or these kind of people who invest on money and really get into this clear aligners and all these kind of businesses. So we are speaking about orthodontics and ONP, where we need to have organizations coming forward and investing on this technology where they can really democratize this whole thing and really get into the real market and help the patients who are suffering for various aspects. So with that, I think this HP, they have really worked on the global market. They have brought in some good success stories, which we shared in the previous sessions, what I had handled yesterday and today. So what we feel is basically we really get work with all the doctors and doctor community and associations around really to really take it to the various patients, and as a responsible person, we also would like to bring down the cost because we have the technologies which can really give you in an economical way. So if you are able to balance between the cost and the volume, I think this democratizing this technologies and really reaching out to the needy will be much more easy for us. And we are also started working with a lot of startup companies who have started launching new products. So one example I shared yesterday was the Makerspace, where we were involved from the day one of their conception of this project, and we really helped them to really do the prototyping, bring a product into the market, and now we are supporting them on production till they set up their own facility at their premises. So what we are trying to do is basically we are helping the startups to really bring in, use the technologies and bring in the right solutions. And we are also would like to work with the team of doctors who can help us in designing this ONP or the dental part of it, and really take it to the needy people and implement this technology for a mass production environment. That is one part of it. Second part of it is, as I said, for the clinics and doctors, we also have the solutions right with us. So if any of the doctors who wants to set up a small facility in their clinic and start using these technologies to as a support to really look after their patients, we also have a solution. So all of you can reach out to us, and associations can also help the community to really direct to us so that we will be able to provide you the help. As a person, we are not doctors. We don't have a team of doctors. We are not basically into designs of it, but we depend on the doctors and other designers to design it, and we can help you with the production facility. So we also run a facility in Chennai where we have all the installation of all these machines available with us. So
till you really get a really good sense of this technology or start using it. We can also help in production. We can produce the parts once we have the designs, and we can support you as a bureau where we can do part on demand services for you. So these are the services which we can do that, and I think in the days to come, our team will engage with the team of doctors around, and we will be reaching out to various doctors and with our solutions, and we can see how we can really get it implemented. That's what I can say. That is the support we would like to provide to the community. And it was great that we have got varieties of speakers speaking about different aspects of it. Doctors speaking about how they treat the patients, designers speaking about how they design it, and people who are implementing it speaking about what are the care we have to take it, or in the design as well as for the implementation. So it was a great session. Thank you, Dr. Shibu, for organizing such an event and really bringing the leaders into for the discussions. And I think the community is going to get benefit, and the doctors or the students who are in the community can also learn a lot from these kind of sessions and really direct themselves into the right, choosing the right profile or field where they can really develop and get it done. So tomorrow, next generation, most probably they will be using these technologies much more than what we used to in the earlier days. So hopefully this technology is going to grow, and this market, we would like to see the growth and implementation happening much faster. Thank you very much for the panel. Thank you very much, Dr. Shibu, for giving me the opportunity. And we wish to work with all of you and take it forward. Thank you.
Yeah. Thanks, Mr. Venkat. I think it's absolutely important that this technology is used. Whatever new things come in, it has to be for the benefit of the patient, but also we need to be extremely careful in the way in which it is basically used. I mean, we have had issues with, these aligners, which, I think our orthodontic colleagues and the association was very upset that a lot of quackery was happening over there with, not qualified orthodontists doing this kind of thing. So I think a word of caution, which I would like to definitely state, is that it needs to be done. I mean, whatever technology you're using, it needs to be brought in, but it needs to be done in a proper scientific way. And the outcomes are dependent on clinicians. So that's absolutely important. And I would like to definitely say that, bring in technology, but let it be by the skilled people who are, who can make a big difference when you use this technology. Otherwise, an abuse of this can actually have a negative impact in terms of outcomes. So that's something which I, as a clinician, would like to definitely affirmatively say that it's something which needs to be driven by the clinician who is appropriately trained to do that kind of thing.
Yeah, Dr. Girish, I really agree with you on that front. And I think that is one of the reasons why I just spoke about bringing an organized sector and getting the mass manufacturing mode. Because so if you look at companies like Smile Direct or iOrthotics, they are specialized in one area of their work, and they just keep doing the same work again and again. They have a team of doctors, experts who really work day in and out to really progress themselves and bring in the record corrections as and when required. So I think adoption of a technology is very difficult in the sense that we need to really dedicate yourself and get the know-how through practice and experience. And a dedicated team is going to help us. So let us really think about some big facilities where they can really bring in this technology and use this technology to really serve the community in a much more economic way, so that more and more people can really use this technology in the field. Thank you very much.
Thank you. Shiva, you would like to comment on anything?
Good afternoon, sir.
Yeah, please go ahead.
You can hear me, sir?
Yeah, we can.
Yes, sir, nothing, sir. I think I should thank Shibu for doing this. It's good that many of us from different lines have joined in to give a presentation. So, only thing I felt is simulation will play a major part in 3D printing also, no, sir? So I think if we could have someone, engineers or somebody in that line who would come in, would help us in the future. That would also be a good part.
Yeah, so Dr. Shiva, we have a team of simulators already on board with us. Simulations, I would say, and also simulators. When I'm talking about simulators, these are This is one technology which we also address through 3D visualization yesterday on dental, very specifically. Yeah, there's a lot of work happening in this space. Dr. Girish, I think it was a great learning yesterday that we had. It was a combination of both 3D visualization and 3D printing, because both are going to complement each other. Because there are certain areas that probably could be really clearly defined with simulation and simulators per se, as in the device itself. So I think while I also get to know from what Janardhan did mention, and also Dr. Pranav did mention, that we need to establish more centers like these. That is definitely there. But as you rightly said, sir, it has to be a process of validation also. The products and the process and the people also need to be validated to build it from there. So there has to be a structure to follow. I will not intervene in between. Sir, carry on. I think the other two respondents also needs to respond.
Pranav, do you have any other comments to add on?
I have 4 quick points. So I think that before it was like how good a surgeon is I think in an indirect fashion is how good a engineer he is to do exact resections, right? But this that is one thing. So I feel that this is a perfect amalgamation of engineering and medical sciences. When I say that, I also mean that senior people or the association people like you or people like Shibu, we should also work on things like and easing out the policies which are required for like in medical industries. So when I say that, people are like, when we do that, it's like, follow the US FDA. So you do have US FDA, and that's, I think, is completely, it's not fair enough. See, the error of our population is the total population of that country. It's a developed country. So comparing the same norms with a country which is developing for last 5,000 years is unfair. So senior people like you, we should work with the government and we should tell them that for India, if you want to enter into the medical market, we should all try to ease out on the the approvals or the FDA approvals, and also we should also work on how we can, or how the startups or the existing countries can not export to developed countries, but at least we can give our implants to Sri Lanka, Bhutan, Nepal, even African region. How we can ease out that process is the responsibility of the people who are sitting, at a very high, because they are giving us the implants and we are buying them. So we are converting our money into dollars, and this is how they are developing more faster. But what about us? So we need to have our own system to enhance ourselves. So I really think that senior people who are sitting should convince the government that depending on the biology or the ecology or economics of our country, we should have our norms, and not just we should copy the norms of a developed country. That will never match. And that is why I think, like, sir, people like you should become the Robin Hood, should take the money from the rich and to give to the poor. So yeah.
I have one comment regarding this, sir. Because as Dr. Pranav had said, there are no ISO certified and there are no labs in India which can give ISO certification for a product. We have to go abroad to get each and everything certified, ISO certified, and it costs in lakhs. Frankly, there is no lab in India. But then, if Indian Institute of Sciences is now opening up even a medical college why didn't they come up with a lab for people who are into research to accredit their products or similar certification like ISO? Why don't we in our own country have a certification?
Exactly. Because now the labs, sir, Shiva sir, the labs are there, but they are accredited with Canada or England,
Yes,
UK accreditation. But we don't have anything. See, we cannot be always like, follow that what they are following and like that. So that is, I don't think that model will never work for India, I think. So, yeah.
We can follow the quality, but as I say, but getting it done only by them, we have to pay them in lakhs and get the product done and then get the certification. Why not get it done here? We have Indian Institute of Sciences. Why not get a facility done here? Like engineering colleges have their own incubation center. IIT centers have their own incubation centers. NITs having their own incubation. But none of them have come to certify a biocompatible material or any material as per the standards of ISO. I think it's time that India has its own labs to certify the products.
Absolutely. I think any new technology has its teething issues, and I think probably the government is doing a lot now in transforming the way in which we are looking at these aspects too. In fact, the starting of the National Institute of Additive Technology in Hyderabad itself is a very, very big step. And that is what they're looking at. That's where we had a big meeting a couple of months back in Hyderabad on just this technology. And I think it's a very, very progressive thing. This is from both the government of Telangana and government of India, which is taking this up very, very seriously. And I hope these outcomes are going to be beneficial to everybody, be it the industry, be it the clinicians, or be it the academicians. And that's where I think things like this is going to be a game changer. And yesterday, in fact, Dr. Giridhar Gyani also mentioned the same thing where, today, Make in India is a very, very big concept. And it's heartening to see the way in which people have started adapting this technology. Just a couple of years back, I'm talking about 4 or 5 years back, even to get a 3D printed patient specific mandible, I had to send it to Israel and then to Singapore. We had a huge queuing system, right? My patient had to wait for almost about 4 months because so many cases were there. And today, if I call up one of the companies, they're able to send it within a couple of days, and that is heartening. And the quality is probably as good or even better than what we got from there. So that's something which is really, really good. So standardization and doing quality control and documenting this. You see, the thing which we also need to start doing is documenting all our complications, publishing these kind of things so that you're honest about the whole thing. And I think it's time that we as a body, as a nation, start publishing our own data. And I've been telling a lot of youngsters, please, you have a camera. What is so difficult today in documenting a photograph? You have to document every case. We need to bring in a discipline that every clinician actually, if you have done, let's say, 50 cases, you have everything from start to scratch. You follow the policies, you have the CT, you have the photographs, you have the outcomes, and you look at patients' input also. You see, that's another very, very big thing which we need to look at too, right? What's the feedback from the patients? Were they satisfied with the kind of results which we have given? Is there a room for improvement? And when you get it from the end user, probably that is where ultimately you will get the best benefit. We as clinicians can give you, for the industry, a lot of input, but ultimately it's the patient who gives us the feedback, right? So I think the full circle will go in such a way that I think as a country we have to grow. And I agree entirely with you guys that we start looking at ourselves rather than looking at the West for every solution. And I'm glad that we are all talking today. I'm so happy a forum like this has brought in clinicians, academicians, industries, startups, everybody together so that we can actually have a win-win situation. Thank you. John, you would like to, say a few things?
I think everybody summed up most of whatever we want to say, but I think it's a lovely time in India for the technology and the application. For me, is technology needs to be accessible to more and more surgeons. Every day we are having new doctors inquiring. So I think if you'd ask me, maybe all the companies put together, if you would ask, I think we only covered about maybe 17% of the total population that needs 3D printed work or technology based work. There's still a lot more to be done. There's still a lot more to be done. And I think, Shibu, the initiatives that you're taking are great. Continue to do so, continue to connect more. And I think with Girish Rao sir at the helm of things, I think it will be it's going to be a wonderful journey for us. It's going to be a little bit more practical, accessible journey ahead. And sir, whatever you need from us, the support is already there. Norms will always be there. It's good we have norms. It's good we have standardization, because that's something that we can look up to. If you don't have norms, then every Tom, Dick, and Harry will start doing things, and we will spoil the industry. So I think norms are good. We need to stick to it and follow as much as possible. That's my take on it. I think Pranav is doing a great job with Lucid, and the other people also. So we would like to look forward to work, collaborate, and see what can be done more.
John, I always like competition.
Yeah,
Only if you have
that's it.
competition, that's
Yeah,
when we
correct.
grow.
That's
Right?
what I happen to say.
Otherwise,
Correct.
it's absolutely important that we have somebody to say, hey, I can give you a better job. In
Yeah.
fact, when I was doing my post-graduation, sadly, one of my colleagues is not there, Dr. Vinod Narayan. And I always used to joke with him and said, we both became very good just because we used to fight so much against each other. We wanted to be in the top slot, and that's how both of us, evolved, and we were so passionate about it. And I like the concept that both your companies are doing very well, and you're partnering very closely with AMSI. And I'm looking forward for a lot of support, a lot of educational activities. In fact, I want both your companies to start funding us to do a fellowship program in 3D printed technology. I mean, nobody has done that, so I'm really looking forward for that. If you guys can pitch in, I'm not asking too much, but if you can, you see what happens is we give them a full training. It's not just clinical. They go into the labs, they go into newer research kind of. Maybe I can send them to IIT Mumbai and ISC Bangalore. We can talk to some of the fantastic guys over there. I mean, it was a game changer for me just to learn. And then they even go to a startup to see. And I want more and more of maxillofacial entrepreneurs, right?
Correct.
I want them to really lead the industry, because as a clinician, if you can understand the problems, then you can really have some really, really good course correction. So that's what I'm looking at. So I'm hoping that you guys are going to fund us in that. Maybe even Shibu can actually pitch in some kind of help for us, and I can really make a difference and be a game changer for AMSI in terms of bringing in new fellowship programs next year. And I
True, sir.
promise next year I'm going to have a 3D printed technology conference exclusively by MSI, where we invite other speakers too. And we showcase what's the work which is happening, and we all learn from it, and we improve, and more practitioners can, start using this technology. So I'm really, really excited that this technology is, being adapted so quickly by a lot of youngsters, and it's going to make a huge difference for patients. So I'm going to push it to the maximum extent.
Sure.
Thank you so much, sir, for the passion that you have. And as Dr. John also mentioned, you're very open to discussion, and you're very pragmatic and very open to, and very comfortable in terms of reaching. I mean, I felt myself, in terms of when I had my first interaction with you, Doctor. And as we all discuss about democratization in terms of 3D technology, that's the course. And for us also as 3D Graphy, that is where we are trying to build as a consortium. So like Dr. John, like Dr. Pranav, we've also identified maybe 8 to 9 smart respondents who are actually coming with that kind of a, for a pathway to come in the direction to take the course forward. So that is how there will be more, traction for this technology going forward. And we will also get more solutions coming forward. Somebody like Mr. Janardhan is also looking at selling his machines and solutions. So we need to have more
I think
companies, more startup companies maturing as entrepreneurs, as you rightly said. Somebody at the helm is Dr. Dinesh Jain, sir. Now he is somebody who loves us as a clinician. He likes being there, with his patients. But at the same time, he also has to run an organization, a dental lab. So I have been to his center, sir, a great center that we could actually relate. I mean, one of the best one that I could see. So I'm saying we are looking at these startups also, starting that first the risk takers advantage. But I've also seen, because this technology is gaining a lot of prominence and has a great potential, startups are also taking that leap now.
Absolutely.
And then supported by investors. Now, what we've done is, Doctor, we also have an investor panel just recently joined last year, actually. We're building on it. So there are 7 investors who have also joined 3D Graphy as a consortium.
Right.
And what we're doing is we're also trying to tilt towards 3D technology, because our focus is 3D technology. And we are also saying that why don't you look at this startup to then invest in this company? So that is also our larger interest in terms of looking at that as taking this to the next level, and also creating more IPs, because creating more intellectual properties are very important. As the NCAM also have a clear vision in terms of also the Ministry of Information Technology and Electronics, where they said that 500 IPs using 3D technology is also the next big thing that they are looking at. So I think we are in the right process in terms of leading the right way, and with your guidance with the association, and also as Dr. Giridhar Gani ji said yesterday, now we are looking at starting up with this first, he said almost 700 active hospitals where they can also have a POC. A great initiative that Dr. Pranav is also doing. But I'm saying they are looking at something in terms of actually instituting it. So we are also now very keen to sign up, and that will happen very soon, to start with 70 hospitals in the country. And then also work with Dr. John, Dr. Dineshji, Dr. Pranav, you also, sir, as an association, and also Janardhan. So that's the clear agenda for us to take things forward, because all of you are experts in your own domain, but somebody has to take the way forward. Is when it comes to media or creating consortiums like these is our job. So we would probably want to take that as our, because we are passionate doing that, and we know that we can do our bit in terms of being committedly working towards it. So thank you so much, sir, and thank you for being our session chair for this day, and also starting with your first presentation, and thereafter all the presentations that we heard. I think some intellectual minds had shared their thoughts on the subject, and I think going forward we definitely can work in conference. Sure, definitely, sir. We will see that how we can work in conference. Thank you so much, sir.
Thanks.
Your conclusion statement, sir, and then we will close.
Well, it was a brilliant learning experience for me. I mean, both the days I sat through 2 sessions. It's been a fantastic experience. 3D technology is something which is definitely a game changer. I'm passionate about it. From AMSI, we are very, very keen that we adapt this technology. We would love to collaborate with other clinicians from different specialities, so that we learn from them. It could be orthopedics, or it could be even prosthodontic society, where we learn from them. And I would like to bring in academics and the industry together, so that it's a win-win situation for everybody. So I'm super excited, and I'm looking forward for a lot of interactions, a lot of these kind of meetings, and let's all work together and ultimately serve all our patients in our dear motherland, so that we make India great again. Thank you.
Thank you, sir. Thank you so much. Sir, I would need everybody's videos to be on, just to have a final capture, as we do in all our physical events. And we are also waiting for our physical interactions also happening very soon in the next 2 months. So that will happen as a course, as Dr. Girish Rao ji said. We need to also have physical events. So yeah, Janardhan, if you are actually comfortable sharing your video, and also Dinesh ji, thank you. I'm so sorry to rob your lunch time. Actually, when on a Sunday when everybody needs to be relaxed. I'm so sorry about it. Mr. Janardhan, are you there?
I'm there, Shibu, but I'm not a person to be switch on the video because I'm having lunch.
Not an issue. So we'll just capture this with a cheese.
Okay, I might not be in the normal formal dress, but okay, you can
capture. Yeah, you can not an issue. We're all casual. I'm just going to take off my coat in some time.
Yeah, that's fine.
Thank you so much. Thank you. Thank you, sir.
Okay.
Thank you very much.
Thank you.
Have a wonderful day. Thank you.
Thank you. And have a nice day.
Thank you.
Thank you.
Thank you. Thank you, sir.
you.